A very good evening to all my dear precious students. How are you all? So today we are going to start with ophthalmology discussion. Now, see, before I start this discussion, I need to explain you something here, that how are we going to go with the discussion now. It is going to be a very quick and a fast revision, and it will all be image based questions. So, have you all attended my NEET PG revision sessions? It's still there. You can watch that as well. So, that was more question oriented and in more detailed form, that is why in 2-3 parts. Now, this time, because we have done that, we are going to be quick and we are going to discuss all image based questions. So, you know how you are going to benefit the most? You will be benefiting the most if you are seriously sitting on your desk with the copy and the pen in your hand. What are the things ma'am is discussing? What are the things I should know? And it should be like a enjoyable journey where you are revising with me quickly about all the points. So, everybody who has read nicely and attending this session is really going to enjoy it. Okay, I hope you got this. Okay, so tighten your seat belts and let's start. And of course, any doubts, I am here for you all. Right. So, we start with the first one. Chalo, keep answering this. What is the side? This is a very simple, but of course, it is all INI-CET questions. I am mainly going towards a little bit more advanced or a little bit more advanced discussion. So, you will have to be very, very alert. If you have read it properly, you will enjoy it. So, what is the site of the lesion in this patient? It is a very simple question. You can see in the grey scale that it is the left eye where it is the nasal field is gone, right eye temporal field is gone. Now, this is one of the most important questions. Every year you get one question on visual field defect, isn't it? So, tell me this one, it is what? Because both are on the right side, this is a right homonymous hemianopia, isn't it? So, if it is a right homonymous hemianopia, don't we know that it is always the left sided lesion which will lead to right sided field defect, and right sided lesion will lead to left sided field defect. So, what should be our answer here? Why are you all answering C? This is a right sided field defect. Can we see this? This is the left side, this is the right side. So, this becomes a right sided field defect. If it is a right sided field defect, it will be the left optic. So, answer is A. It will be left optic tract. Homonymous hemianopia has to be due to optic tract lesion. ये तो हम सबको पता है, right? Okay. What about one by one central chiasma? Can you tell me central chiasmal lesion? So, we are revising. I am not going into details of visual field effects. As I said, you can watch in that session only. Okay. So, we come to the next thing is about central chiasma. We all know when the central chiasma is affected, it means both side nasal fibers are gone. And if both side nasal fibers are gone, you are going to get a bitemporal hemianopia. Good evening all of you, good evening. So, we are going to get a bitemporal hemianopia. Let us focus. Let us try to enjoy the session. Let us try to revise as much as possible. Keep writing. Please do not just listen. Even if you know, write it down. Okay? So, if you will write it down at the last moment, just looking at what you have written through your own hand is the best thing that you will get. Okay? So, do that. So, this is your bitemporal hemianopia. We are clear with this. What about if it is an anterior chiasma? What did we discuss earlier? Anterior chiasma means this is also called, okay, before that, what is this image? This is again seen in central chiasmal lesions, okay? Central chiasmal lesions. And what is this? This central chiasmal lesions, this is your seesaw, one eye up, one eye down. So, this is your seesaw nystagmus. We will keep this in mind, exam question. Again, right? Okay. What is this field defect? This is what is your anterior chiasmal lesion. I have discussed this earlier also, that how, what is the Wilbrand's knee, right? So, how the Wilbrand's knee when it is affected, and that means the lesion is at the junction of the nerve and the chiasma, isn't it? So, because these are inferonasal fibers, you get a superotemporal field defect. Either you can get total blindness or you may get central scotomas if some part of the optic nerve is involved. Should I say it again? I am saying at the junction of the optic nerve and chiasma where some fibers of nerve are involved and some fiber of chiasma. Therefore, you will get, and what is that? For some fiber of chiasma, what do we mean? We mean Wilbrand's knee. Again, details please If you want to know more details, listen to the earlier session. So this is your anterior chiasmal lesion. We also call it what? Junctional scotoma of tracar. ठीक है? Right? So junctional scotoma of tracar. So if there is a left sided, it is written here left eye. Yeah, this is written left eye, right? So अगर ये left eye में पूरा आपका blindness है, that means left eye optic nerve is involved, right? And right sided your Wilbran's knee is involved. Are we clear with this? This you should be very clear about the sides. So this is what you are seeing in this image. Now is it fine? NNN, right? Yes, very good. Yes, Shruti, it is junctional scotoma of tracar. Okay, this is tracar. Tracar is the name of a scientist. We are saying junctional scotoma of tracar. I'll do that from the next slide. Okay. We come to the next image now. Let us see what we have. Okay, can we see this very clearly seen here? What is this? Quadrantopia. Which side? Superior quadrantopia. Everybody knows it's an important exam question. Pie in sky. We also call it pie in sky. Now is it okay? Now am I writing properly? Okay. So pie in sky is a feature of, क्या बोलोगे? We all know this, temporal lobe. Any temporal lobe lesion, right? So temporal lobe lesion means inferior fibers which are looping around, what do we call them? Mayer's loop, है ना? तो वो Mayer's loop, when that gets affected, you are, the inferior fibers are gone, so you get superior quadrantopia, correct? So all these points that I am discussing here has to be revised properly, yeah, important for the exams, ठीक है? Okay, अच्छा, another important thing that you have to keep in mind, what else you get, this was asked again in the INS question, that what you are going to get as in a temporal lobe lesion is formed hallucinations. You can get a formed hallucinations, right? You must be knowing more in detail about temporal lobe lesion, you must be remembering more than me also. Okay, so we come to the next image. What is this? I think you all can quickly relate. We are now talking about inferior quadrantopia. This is pie in floor, and pie in floor is a feature of parietal lobe. चलो एक और क्वेश्चन पूछती हूँ आपसे. Parietal lobe lesion, which parietal lobe, which part of the pathway, optic radiation pathway is this affected? It is mainly anterior. As we go into the deep parietal, we will get homonymous hemianopia. So remember, pie in sky, pie in flow, many of you have asked me, this is incongruous, ठीक है? After that, when you go into deep parietal, that is posteriorly in the optic radiation, it becomes congruous, and of course visual cortex lesions are always congruous, ठीक है? Yeah, so we will keep this in mind. Yeah, so that is spelled as, bombs is spelled as this. So the fibers are called bombs loop, bombs ये वाला bombs है, ठीक है? वो वाला नहीं है. So वो वाला fibers, those were Mayer's loop, this one is your bombs loop. Correct. Very good. Why, you all keep your such a complicated name that whom I am saying very good is also very difficult. All of you very good. Okay, so bombs loop. Then we come to the next image. What is this? Pay attention. This was again your INI-CET exam question. What are you looking at? LGB lesion. This part is supplied by anterior choroidal. Anterior choroidal का color देखो. See this? So if the anterior choroidal artery is blocked, what do you get? I am going to get a lesion here, lesion here, lesion here. This is what is called sectoral quadrantopia. But if there is any blockage of lateral choroidal or posterolateral, to be more in detail, then what you are going to get is this part is gone. This is what has been asked in your exam as keyhole visual field defect. Keyhole visual field defect. Right? So keyhole visual field defect is a feature of LGB lesion. Very important exam question. ठीक है? No, Avinash, don't get confused with your this macula sparing. Yes, we are talking about defect. मतलब क्या है? We are talking about scotoma. ठीक है? When you are saying macula sparing, this is the one. So this macula sparing homonymous hemianopia is keyhole vision. I hope now it is clear. So, keyhole vision is seen in occipital lobe lesion, and keyhole visual field defect is a feature of lateral geniculoid body lesion. ठीक है? Clear हो गया? Okay. So, that was one thing, and of course, can I ask you one more question here? When we say macular homonymous hemianopia, I hope you all are clear. Total macular homonymous hemianopia cannot be possible with vascular lesion, because this is supplied by some branches of posterior cerebral artery as well. So, where do you get this? We get it in trauma to the tip of the visual cortex. ठीक है? Keep this in mind. So, this is the reason, and this is how you are going to get your macular homonymous hemianopia. ठीक है? चलो next पढ़ते हैं, ये क्या है? It's already written here, but let's revise it. When you say INO, it is an MLF lesion. Why are we calling it? It is a right MLF. Look here, on the right side, abduction here is fine, adduction here is fine, but no adduction on the right side of right eye. So, this is his right eye, this is his left eye, isn't it? So, this side there is no adduction, that is why right MLF lesion, because wherever the MLF is gone, there is ipsilateral defective adduction. And see what else it is showing? Convergence is normal. In INO, convergence is normal. चलो इसको let's revise it very quickly here. When you say internuclear ophthalmoplegia, we have to remember our horizontal gaze center. So, horizontal gaze center is PPRF, managed by contralateral frontal eye field. I have discussed this in the earlier session in lot of detail, you will listen to it again. So, from here what happens? Let me make my simple diagram, that will be more easier for you all to learn. So, this is what we make. If this is the PPRF or horizontal gaze center of the right eye, क्या होता है? It is going to manage the same side lateral rectus. So, ipsilateral innervation. और क्या? For the opposite side, it will order the medial longitudinal fasciculus of the left side, and this orders the left medial rectus. So, this is also ipsilateral. What is contralateral? So many types I have explained you. Contralateral is only one sided PPRF, other side MLF. So, if PPRF is gone, you are going to get horizontal gaze palsy on that side, and if frontal eye field is gone, it manages the opposite PPRF, isn't it? Therefore, what you will get here? Contralateral horizontal gaze palsy. So, FEF lesion causes contralateral horizontal gaze palsy, and PPRF will lead to ipsilateral horizontal gaze palsy. And what about MLF lesion? This is what you are learning with me, that MLF lesion is going to lead to, this lesion is going to lead to, INO, that is internuclear ophthalmoplegia. Common sense. Let's keep listening. If there is any MLF lesion, what is happening? MR will not work. So, the side where there is MLF lesion, that side no adduction. This is what you are looking out here. So, that side no adduction. What about the other side? That can abduct, but it will show ataxic nystagmus. So, this eye is going to show ataxic. Remember the name of this nystagmus, please. Ataxic nystagmus. So, this questions on horizontal gaze center is asked, you should know this. Okay, it also reminds me, this was a recent AIMS question about, I am more used to saying AIMS, I mean INI-CET only. So, recent question about vertical gaze center. So, I hope you know the name of the vertical gaze center, all of you. क्या नाम है vertical gaze center? If we ask, so what are the components of vertical gaze center? Let's revise that it is generally rostral interstitial MLF. Don't forget this, RI MLF, and of course INC, interstitial nucleus of Cajal, right? So, and posterior commissure. These are the three main components. Just we will remember this. They will only ask you the name, nothing, no details in the vertical gaze center. Okay. Another important point I remember, vertical gaze, I hope you are noting it down. I really hope, even if you know it, you are still noting down that today sitting with the ma'am, what are the things we have revised. It will definitely help you at the last moment. Okay? Okay, then we talk about another important thing is, when you have talked about vertical gaze, I was about to tell you something. Yeah, Please, one thing that you have to remember, that defective vertical gaze, आपके level पे if they ask you, you have to remember Perinod syndrome. So keep that in mind, right? A defective vertical gaze, if they ask you, we will answer it is seen in Perinod's syndrome. Chalo. So, right? Convergence, retraction, nystagmus, right? Light near dissociation, all the features एक बार revise कर लेना. All of you revise this, right? Perinod syndrome, and of course defective vertical gaze. There is also lid retraction, Collier's sign. So just revise this. Yeah. So yes, all of you. What about 8.5 syndrome? And what is 1.5 syndrome? चलो समझते हैं. What is 1.5 syndrome, all of you? So you have made the diagram. So one side both PPRF and the same side MLF is gone. What will happen? Why did I rub this? I didn't see your question. Okay, I'll quickly draw it again so that you are easy to explain you all. So if this is the PPRF, this was the LR. Okay, so now all of you tell me. If what is 1.5? सबको पता है? One sided, suppose this is the right sided PPRF and right side MLF, both are gone. खुद सोचो, think with me what is happening. If both are gone, what is happening? PPRF is gone means no adduction on this side, no abduction on this side. And because there is MLF of this side gone, so no adduction on this side. So one sided, when both PPRF and MLF are gone, एक तरफ no adduction, no abduction, and opposite side only no adduction. This is what is 1.5 syndrome. This becomes your 1.5 syndrome. And now coming to the question of MS नाम रखा है. So what is the 8.5? Do you all know what is 8.5 syndrome? It is 7th nerve palsy along with 1.5. Now I will ask you one question, all of you. How many of you have answered this? Kabir, MS. चलो मेरे एक सवाल का जवाब दो. 7th nerve palsy on which side? Quickly. 7th nerve palsy. And then why don't you just focus on what I am saying? I am speaking also. I am not only writing that, right? So let's just focus on that. MS, what is the answer? Very good. Yes, it is on the same side. Come to the next image, otherwise we won't complete. Now why I have included the slide so that I don't forget to tell you, these points can be asked at the INI-CET level. Please keep in mind what is bilateral BINO क्या होता है? What is bilateral internuclear ophthalmoplegia? So in this I hope you remember, if I look at if the patient is looking at this side, then again nystagmus here and defective adduction this side. If he tries to look at this side, this time defective adduction is this way and there is ataxic nystagmus on the other side. So this is called bilateral. And what is Webino? Webino means apart from this bilateral INO, there is manifest exotropia. Is it now fine written? Likhne ka NNN? Now is it okay? So it is manifest exotropia. That is why we call it walled eye bilateral internuclear ophthalmopathy. So in primary gaze there is a manifest exo means divergent squint. Okay? And we already know about 1.5 syndrome. So what else we learned about? Bino and Webino. Chalo. Ye kya dekh rahe ho aap? What is the slide? All of you quickly answer this. I will go to the next one then. We have lot to discuss today. Chalo 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 batao. अरे भाई हाइलाइटर से कैसे कोई लिखता है? हाइलाइटर से हाईलाइट होता है ना. ओके, लेट मी ट्राई. ओके, ऑल ऑफ यू now you can tell me what is this. The baseline is, can you see, all of you focus on this. What is the diagnosis of this image? All serious ones. Can you please answer me what is the diagnosis of this image? Quickly, quickly. CNN, that is why I am telling you, you have to focus on what we are speaking rather than on pens and highlighters. Come on, answer this. Very good, Jitin. So it is not INO. Always very quickly look at the primary position. In primary position, can you see here? What do you see? One eye is, it is not, both eyes are not at the center. Just keep in mind, in INO, both these will be in the center. So actually the diagnosis here becomes 1.5 syndrome. The diagnosis is 1.5 syndrome. ठीक है, चलो नेक्स्ट पढ़ते हैं. What are you now looking at? Neuro-ophtha is very, very important, so I have included maximum slides of this chapter. Can you see here there is anisocoria, all of you? Right? This is your right eye. Lao bhai, highlighter. This is your left eye. How can you use a highlighter? See and what is happening? Chodo, don't waste time. So this is your left eye. What do you see? What is the arrow telling you? What is the arrow telling you? Avinash, are you answering for this one? Yes, this is anisocoria. Which eye is mid dilated? Left eye. Can you see that? Left eye is mid dilated. Matlab kya hua? And if this is happening at the daytime, now tell me what is the diagnosis? This is a middle-aged women complaining of anisocoria, complaining of photophobia. There is anisocoria more during the day. What is your answer? What is this pupillary defect? Pupillary defect. Quickly. Bolo. Batao. What is the pupillary abnormal pupillary reaction here? This is what is Holmes-Addy pupil. We will not forget it. Again, I have taken this in detail, earlier session, revise it. Holmes-Addy pupil. ठीक है? So Holmes-Addy pupil or tonic pupil, सबको you have to revise it properly. Can you tell me how we confirm the diagnosis? Yes, very good Kalyani, very good Dark Knight, 08. And Dr. Prasad, very nice. Can you quickly also answer this? I can keep speaking, but then it is not interactive. Maza nahi aayega. So all of you answer me this one. So how do you confirm this is Holmes-Addy? I am going to the next slide. Quickly, I need the answer. No. Which test? What do you test? This is on examination. Vermiform movement of iris. Yes. Which will happen? It is tonic pupil. Everything agreed. What is that test? Perfect. Yes, Jitin. It is 0.125%. Please remember. Of pilocarpine with even such a small concentration, what you see is that it will constrict due to denervation hypersensitivity. Well answered, pilocarpine test. Okay. So, we will remember this. Chalo. So, anisocoria, if it is more in the dark, then what is the diagnosis? We are very, very clear of this. This has been your INI-CET question, Horner's. Isn't it? They had asked you this question that this patient has a constricted pupil in the day, it is also in the night, and there is so what is the, and it is not dilating in the dark. Hai na? So, what is the diagnosis? Something like this. So, please remember Horner's syndrome. We all know. Horner's, quickly batao kya questions pucha. You all know what is Horner's. I am not going to theory. I will only discuss questions. ठीक है? अब इसमें क्या क्या questions आ चुका है? Answer me. Horner's is best described by which two features? जल्दी बताओ. Horner's is best described by which two features? Okay, Dr. Prasad agreed. Cocaine test we do or not do. First of all, on examination, tell me Horner's is described by which two features? Answer me this. I am only focusing on the questions asked in your exam. Quickly answer me. Holmes-Addy we have done. Pilocarpine test, anisocoria, middle-aged female, tonic pupil, all things we have covered. Acha, aapse this question has also been asked in this way. Please keep in mind that if a patient is, what is the position of pupil in Holmes-Addy? This has been your exam question and your answer has to be mid-dilated. It is very simple if you know the thing. Okay? So, these are the questions related to this. Then of course, I am still waiting. Jitin, exophthalmos or inophthalmos, and inophthalmos is also not a true inophthalmos. So, actually best it is described by ptosis and meiosis. Ptosis and meiosis. So, it is best described by ptosis and meiosis. It is an apparent inophthalmos, isn't it? Please correct yourself. So, agar aapse this has been your AIMS question, two features which best describe Horner's, please answer this. And is it congenital or acquired Horner's? Horner's kya hota hai? Both. How do you differentiate? If there is heterochromia iridis, then it is a congenital Horner's. Heterochromia iridis means it is a congenital Horner's. ठीक है? Done? Okay. So, we come to this one. We come to the, acha, one last question on the pupillary reaction, all of you. Of course, you know what is relative afferent pupillary defect. Please remember, this is the first sign of optic nerve disease. This is one question and it is diagnosed by swinging flashlight test. We will not forget this and we will revise this. Argent-Robertson pupil, everybody knows, is light near dissociation, where light reflex is absent, near reflex is present. Done? Yeah. So that is mainly due to lesion in the pretectal nucleus. Okay, we come to the next slide. This is an interesting question which will revise and test all the knowledge of your retinoscopy. Let's read the question together. On performing refraction using a plane mirror up on a patient who has refractive error of -5 diopter sphere with -1 cylinder at 90 from a distance of 1 meter but no cycloplegic. So if you know the process of retinoscopy, now you are doing a reverse gear. The question here is telling you that ठीक है, this patient is using ये वाला specs. Tell me when I first tested him, what was the movement I was getting on retinoscopy? So this is the question. Interesting? Let's solve it. When you say -5 diopter sphere, make a retinoscopy 2 lines, make 2 lines here for the retinoscopy. When you say -5 diopter sphere, we know -5 is here also, correct? When -1 cylinder at 90, don't forget that axis in the prescription is mentioned opposite. अगर वो लिखा है -1 at 90, I will put this -1 at, what has happened to, okay, so I will put this -1 at 180, ठीक है. So when I put it at 180, now my retinoscopic reading क्या हो गई, -5, -6. अभी आपने बस, you have done only one thing, you have converted this prescription into retinoscopic reading, that's it. But do you realize this is a corrected reading? We have already subtracted the correction factor, then only we have given a prescription. So now you go to uncorrected reading because you have to comment on the movement. So what was the correction factor? It is given in the question, it's at 1 meter distance. No cycloplegic. What will be the correction factor? Everybody knows, it is 1. You had subtracted 1, now you are going back, so you add 1 here. Now your corrected reading becomes -4, -5. ठीक है? So ये दोनों minuses myopia more than 1. We all know this. Everybody knows this, that when you talk about, yeah, so we all know this, when you say that myopia more than 1, it is against the movement. Less than 1, or if it is hypermetropic or emmetropic, then what happens? This is with the movement, and no movement means equal to 1. So that inference you have to remember. ठीक है? अब बताओ क्या आंसर हो गया आपके सामने है. If this is -4 and -5, it means myopia of more than, so this will be against the movement in both the axes. So Jitin has correctly answered. Thank you so much. So we will answer against the movement in both the axes. Chalo. So a few quick slides on this so that we revise what has been asked in INI-CET in this Snellen's box. We all have discussed that in lot of detail in the NEET PG section. Just see that when you talk about Snellen's acuity chart, what is the angle subtended by the whole letter? We all know 5 minutes and margin 1 minute. So minimum angle of resolution is 1 minute. What is then different? We know what is different is, this is done at 6 meters and understood? I have explained this to you. Sorry. Okay. So if every letter is subtending the angle of 5 minutes and margin 1 minute, what is the difference? E is so big and DNHO BUC is so small. So what is the difference here? Distance. The same angle is subtended, this subtended here at 6 meter distance, but such a big letter, this will be 60 meter. So your concept should be absolutely clear, and I hope you remember the question asked in your AIMS exam, and what was that? They had asked you about, agar 6 by 60 is subtending the angle of 5 in 1 minute at 60 meters, this we are clear. What about 6 meters? You remember this, na? This question, you all must have solved it in your preparing. Yes, very good. So many of you. So if at 6 meters, this 6 by 60 की line में, what is the minimum angle of resolution? We generally reverse the fraction. It becomes 60 by 6, which is 10 minutes. And because you have to always be 5 times for the whole letter, our answer becomes 50 minutes. Right? So what is the answer? This was your, I have just taken the question that has been asked in your previous year exams. right? So this was your question asked, 6 by 60 ka letter, how much angle it will subtend at 6 meter distance. How will you solve? Quickly find out the MAR. How to find it? Reverse the fraction. जो भी निकलता है multiplied by 5, you can get the answer. So now if they ask you for any equity line, you will be able to say. Chalo, we come to the next. What is this? What is happening? Very quickly all of you. Yes, very good Jitin, it is 50. Shruti, very nice, it is 50 meters. 50 minutes, sorry, it is 50 minutes. So now this one, all of you, this is indirect ophthalmoscopy. What are the questions they have asked you? And believe me, they are still asked many times, a lot of repeated questions on these two instruments. So indirect ophthalmoscopy, recently asked question, where is the image formed? So here the image is formed between the examiner and the lens. So image is always formed in the air between the examiner and the lens. Type of image, real and inverted. है ना? हम क्या बोलेंगे? Real and inverted. What is the magnification? It can be 3 times or it can be 5 times. Okay. How do you calculate the magnification? It is power of eye upon power of lens. Don't forget this. Power of eye upon power of lens. So commonly used power of the lens, 20 diopters. So power of eye, that you have to decide. So now alert हो जाओ. I am asking a question here. जब आप कहते हो power of eye, I tell you my patient is a myope of -5. He has a refractive error of -5 diopters. He is using a specs of -5 diopter spherical. Whatever you want to understand. What is the power in his eye? All of you, answer me this. What is the power in the eye in this case? Quickly answer this. चलो 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 फटाफट बताओ. What is the power in of the eye in a patient with a refractive error of -5 diopter spherical? It's a very simple question. Divesh, फंस गए. So you are trapped. Yeah, good evening Rahul, joining late. Many things discussed. चलो फटाफट इसका आंसर करो राहुल. So if the patient has a refractive error of -5, then what is the power in the eye? What is wrong with you all? What is minus? Nobody is answering correctly. अच्छा ठीक है. Listen here, this is the basics. If this is not clear, this is bad. What is the power of an emetropic eye? We all know 60 diopters. So many times this question has been asked, power of a reduced eye 60 diopters. ठीक है. अब बताओ what is myopia? More power in the eye. If I say -5, actually it is 60 plus 5. So actually it is 65 diopters. Had I said hypermetropia, it would have been 55. Now you got it? Yeah. So this is the power of eye. This is how you will calculate upon power of lens. Got it? Yeah. What about direct? Direct ophthalmoscope, you generally calculate as power upon 4. Okay? Yeah, I have discussed that also in detail there. Just listen to those sessions also. Come to the next image. Achha, direct में one more question was, which eye direct ophthalmoscope, let me quickly revise it with you. It is a 15 times magnification. Image is virtual and erect, right? What is the field that you see is एक बार में 2 disc diameter. You all know one disc diameter is 1.5 mm. What else? They had asked you which eye of examiner, which eye of patient. So if I have to look at your right eye, I will use my right eye like this, or left to left. Just remember this. Okay? And what will you say to the patient? Should he look in the light or should he look straight? He should be looking straight. Why? If he looks in the light of the ophthalmoscope, pupil will constrict and I will find difficulty in actually seeing behind. इसीलिए we ask the patient कि आप सीधा देखो, सामने देखो, and then you are actually seeing the fundus. समझ आ गया? चलो. So ये सब questions आपको direct के, you should be knowing this as well. We come to the next thing that is very important and can be asked as classification of astigmatism. Let us quickly revise. So what is simple myopic means? One eye no number. It is focusing on the retina and one eye it is a minus. What is simple hypermetropic? One axis, I am so sorry, one axis I meant to say. So one axis is plus, one axis no number. What is your compound hypermetropic means both the axes are plus. And what is compound myopic? this is both axes are minus, and mix means one is plus, one is minus. ठीक है? Yeah, and then I was remembering you only that now it's clear na? Yeah. चलो, अब once we know this, do we know another method of classifying astigmatism? With the rule and against the rule. So, if the vertical is more than horizontal, this is with the rule astigmatism. If horizontal is more than vertical, this is against the rule. Do you all have any idea why do you call it? कौन सा rule? So, actually rule ये है that physiologically due to the pressure of your upper lid, it is always the vertical which is slightly more than horizontal. So, if that is increasing, it is with the rule. But if it is opposite is happening, we call it against the rule. ठीक है? Now, what is most important, I am going to put a question here, you will answer me. So, quickly answer this before I go to the next slide. Let me quickly give you a prescription. -3, I am writing anything that is coming in my mind. -3 diopter spherical plus 1 diopter cylinder at 90 degree. I ask you, tell me, comment on the type of astigmatism according to with the rule, against the rule and according to the previous classification. कैसे करोगे? Please always turn it into retinoscopy first. So, turn it, चलो करो, -3 plus 1 at 90 again means 180 पे लगाएंगे. So, it becomes -3 and plus, oh sorry, -2, -3 and -2. Now, tell me, it is compound, myopic, agreed, both are minus. Is it with the rule or against the rule? All of you answer me, I am waiting. Quickly. Yes, Jitin, Darknai, Vaishnavi. Very good, very good. So, it is with the rule, ठीक है? क्यों? Why? Now, do you agree? When I say -3 क्या power होगी? Now, nobody will make a mistake. 60 plus 3 power है यहाँ. And what is the power here is 60 plus 2. More power on the vertical, therefore, it is with the rule. चलो, one last question before I go to the next slide. Answer me this one. चलो, answer करो. If I ask you +3 plus 1. Tell me, is it with the rule, against the rule? Quick, 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 quick. Is this with the rule or against the rule? ये बताओ. This one. Now this is the question here. Oh. This question, is it with the rule or against? Of course, it is compound hypermetropic. Shruti? Very nice. So, some are saying with the rule. It is against. Why? When you say +3, it is hypermetropia. Think with me. Hypermetropia मतलब less power in the eye. Less power in the eye means actual power क्या हो गई? 60 minus 3. What will be the power here? It will be 60 minus 1. Right? ठीक है? So, this is more power in the horizontal. That is why it is against the rule. Okay, last question and then I am going to the next one. Chalo, batao, last question, this one. Tell me, what type of astigmatism is this? Yes, very good. So, this is with the rule. No doubts? Why with the rule? Why with the rule? Because this is 60 diopters na, and this is 60 minus 1. तो ये ज़्यादा हो गया ना, so it is with the rule. ठीक है ना? Okay. चलो, अब next चलते हैं. What are you looking out here? This is what? Pinhole. What are the questions they have asked you in pinhole? Is size of the pinhole 1 mm or 1.25 mm. Both are correct. Okay. Another question they have asked you, and this has been your again INI-CET question, that what amount of diopters you can neutralize with pinhole. Do you know what it means? It means because with pinhole, peripheral rays are cut, so depth of focus is good. So, you may be able to see nicely even without your specs, though you need specs. So, how much it can neutralize? I have practically appreciated up to 2 diopters, but actually theoretically it is saying 3 diopters. So, we will learn 3 diopters. Okay? So, it can neutralize up to 3 diopters. Then this was your important question, so I thought I will mention this. And of course, we all know that if you are using a pinhole and the vision is improving, it is a refractive error. But if the vision is deteriorating, there is some problem at the center. It could be a nuclear cataract or it could be just a pathology in the macula. आसान है? Easy? ठीक है? Okay. Good, Kabir. Thank you. Now look at this one. ये क्या है? This cute guy, what is he doing? What is the sticker on his eye? We all know we are talking about occlusion. So this was first question. What is the treatment of choice of amblyopia? अगर आपसे पूछेगा, what will you answer? Occlusion. All of you, occlusion of which eye? Quickly answer me. Occlusion of which eye? जल्दी जल्दी बताओ. Which eye? Which eye? Which eye? Patching तो ठीक है, Dr. Prasad. Which eye should be patched? In this child, which is his amblyopic eye? चलो ये आंसर करो. This is his right eye and this is his left eye. My question is, which eye is amblyopic? Yes, very good. So his right eye is amblyopic. So we are forcing this lazy eye to work. And how are you forcing? By occluding the normal eye. We will not forget this. ठीक है. In next question सुनो. This was your AIMS question earlier asked. Where is the pathology in amblyopia? क्या बोलोगे? Lateral geniculate body. Pathology in amblyopia, we will answer lateral geniculate body. Right? Okay. And till what age can you treat amblyopia? Ideally, maximum effect can happen only within 6 years of age. Though theoretically we say we can try till 8 years, but it is generally 6 years. Both the facts are actually correct. So we will look at the question, what is the intention, and answer accordingly. हाँ, 8 years wrong नहीं है. If you want to answer 8 years, it's absolutely okay. But practically we have seen that the best results are only till 6 years. उसके बाद it is very few patients respond after that. May respond, so let's answer 8 years. चलो, we come to, what is this you are looking at? Not 10 years at all, okay? बताओ फटाफट, what is this? Which grade of binocular single vision are you looking at? Which grade of binocular single vision are you looking at? Quickly, quickly, quickly. So you have to all work upon this. No, no, NNN. इतना बड़ा allegation. Let me check it again, and you also. And if I made that mistake, please correct it. I have never said. एक बार और सुनना उसको. Okay, just listen to it again. Maybe there is some confusion. I could have never said 10 years. I will check it also myself. Binocular single vision, Ma Vaishnavi is correct, but what is the stage? Nobody has actually answered correctly. Jitin, what is grade 3? It is, what is grade 3? So this was your first question of your exam. Binocular single vision, what are the grades? Batana shuru karo jara. Grade 1 is simultaneous perception. You are looking at grade 1. This is simultaneous perception. I'll remind you what was grade 2. The grade 2 was a horse and a horse with a carrot, and then there is a fusion. So please remember, similar objects can be fused, and this is simultaneous perception. So you, what I am trying to tell you here, my message here is, please keep looking at the slides, it's important for binocular single vision. And Jitin, grade 3 तो हो गया आपका stereopsis ना, how deep is the bucket, or when you are looking at the car which is running relative speed of 2 cars. So it is mainly the depth perception we are talking about, isn't it? So second is fusion और तीसरा हो गया depth perception. चलो, this was the first question. Come to the second question on binocular single vision. Quickly answer me. ये बताओ. Again it develops by, you will answer 8 years of age. Again we will follow the same 8 years wala answer. Right? Okay, NNN, what we will do is, you will just DM me what was the question, I will guide you. अभी आगे सुनते रहो नहीं तो छूट जाएगा. ठीक है? Okay. Then we talk about next question on binocular single vision. All of you, this was your AIMS question, was this one. So this is a test which is 4 prism base out test. I hope you all remember this. When you are putting a prism with the base out, what happens? The light deviates to the base, image deviates to the apex. So if I put a base out prism in front of one eye, this left eye goes in. As a conjugate movement, right eye also goes this side, but if the fovea of this eye is fine, it will come back and take a bifoveal fixation. right? So we have to check that bifoveal fixation, agar wo nahi pakad mein aa raha hai, then this is a very very accurate method and it is only 4 prism diopters. So this is one to test your binocular single vision. And what is the second thing? The second thing we will not forget is it can diagnose. This was your again INI-CET question. It was to diagnose microtropia. क्या होता है microtropia? Tropia is squint, micro is very small squint. कितना small? 5 degrees. 5 degree मतलब 10 prism diopters. ठीक है? Okay, we come to the next slide. Okay, apart from this, yeah, I remember why I have kept this blank slide to remind you, don't forget the Worth 4 dot test. Now I have not included that, you can just revise it in my earlier session, Worth 4 dot test, okay. And one name, you just know the name, Bagolini's striated glass test. So what has been asked apart from this has been a Q. The second is Worth 4 dot. To revise kar lena ek baar, theek hai? Okay. So these are the tests for binocular single vision. And if I have given this list, what is missing? What is missing in the list is synaptophore. Okay? Yeah. Chalo. Now it's time to answer questions like this. Suppose you get this question very quickly, how will you answer? I'll look at first of the, okay, I am seeing the funders, I am seeing the options, I already know what I am looking at. But still, let us see what the question was. So this 50 years old male patient presented to emergency department, persistent cough, worsening of shortness of breath, positive of COVID-19. Okay? And on the day of discharge, I am not reading the whole thing to save time, you can read it yourself. So on the day of discharge, 12th day, he is complaining of sudden onset of loss of vision in the right eye. Okay? Fundus picture is already given. Of course, everybody knows it is CRAO. What I want you to know, this was an important point to remember, that COVID-19 say, for another question which has been recently asked is most common ocular manifestation, follicular conjunctivitis. So one is follicular conjunctivitis and second we have to know is CRAO. These are the two main ocular effects, and of course we will not forget mucormycosis, which was not per se due to COVID-19 but due to using too much of steroids. Okay? Yeah. We come to the next one. See, this is again a slide of CRAO. When you are doing a flow scene angiography, what do you see? No filling. Dye is not filling, there is a blockage. Okay, now this is your question for you. Yes, what we saw was the cherry red spot. Lot of questions on cherry red spot. Everybody knows it. What are the causes of cherry red? Avinash, Bharat? Cherry red spot के causes में, पहला broad heading में CRAO. Second broad heading, Berlin's edema. Third, I generally teach like this, depositions. Just look at the earlier session, we have talked about it in detail. Okay? Depositions means all those gangliosidosis and sphingolipidosis, Tay-Sachs, Niemann Pick, तो उसकी बात हो रही है. ठीक है? चलिए, अब ये बताओ यहाँ पे, what are you looking at in this slide? This is your question, you will answer this. Arrow is indicating what? Quickly, I am already telling you this is a case of CRAO. Now what is the arrow? What is this arrow all about? I am waiting because I want you all to talk to me. It should not be one-sided. जल्दी बताओ मुझे. नितिश, ध्यान से सोचो. We are talking in relation to CRAO. 14% of the population has a dual blood supply to the macula. Ab batao, what is this? All of you. Which artery is this? Which artery is this? No one is talking. No one is correct. No one is correct. We are looking at cilioretinal artery. Now don't make the mistake, okay? Please note it down, all of you. Cilioretinal artery. So if this patient has cilioretinal artery, his central vision and a small amount of the visual field will be left behind. And cilioretinal artery is a branch of, this was your exam question. Cilio, Gurmeet? Nah, yeah. Now you all got it. Very good. Now we are already on the next question. What is the cilioretinal artery is a branch of? Tell me quickly. We'll go to the next slide then. Cilioretinal artery is a branch of, we will remember, short posterior ciliary artery. Okay? short posterior ciliary artery. Okay, so once you talk about CRAO, what are you now looking at? Diagnosis, spot diagnosis. What is the diagnosis? Quickly. I see an optic disc. Batao. Very good. It is short posterior ciliary. Very good, Shruti. This is splashed sauce. Tomato to nahi pata, but splashed sauce. Tomato hi hoga obviously. So splashed sauce appearance, isn't it? And what do you see? What are these white ones? These are, what are these? They can ask you like this. I recently, in 1 or 2 years back, they had given you hard exudates, isn't it? What are you now looking at? ये है soft exudates. याद रखो ये हो गया cotton wool spots और soft exudates. ठीक है, चलो नेक्स्ट पढ़ते हैं. Okay, so ABCD is not given. Okay, I will write it for you all. This is A, this is B, this is C, and this is D. So this is the question, image based question for you all. Interesting question. Focus. All are causes of glaucoma except. Quickly answer me. All are, yes, very nice. Those are soft exudates. We call it cotton wool spots. Yes, Mittu Kumar, that's correct. So which is the A, B, C, D may say all are causes of glaucoma except. What will you answer? I got only 2 correct answers here. ध्यान से देखो. So focus here. Listen to me. What is A? This is your very important INI-CET again AIMS question. This is the slide given in the AIMS. And they had asked you the diagnosis with a small history, and you all know we are talking about congenital glaucoma or ophthalmos, है ना? So this is your congenital glaucoma or ophthalmos. Okay, ठीक है? Done. What about B? Sturge-Weber, port wine stain, you all can see that. So this is a child, if do you all remember Sturge-Weber syndrome? Again it is associated with, what is the triad of Sturge-Weber? It is simple batao, hemangioma on the face, hemangioma in the brain and glaucoma. So that is the triad, isn't it? So ये हो गया आपका port Sturge-Weber. Again this is not the answer. It is associated with glaucoma. And why are you all answering C? What is this we are looking at in the right eye is S-shaped deformity of neurofibromatosis type 1, which is also a cause of secondary congenital glaucoma. Don't only learn the primary, secondary congenital glaucoma. Okay, so causes में Sturge-Weber is also one cause, NF1 is one cause. If you want to note down, aniridia is another cause. Okay, these are all causes of secondary causes of congenital glaucoma. So our answer is what? This cute child, look at it. So this cute child is a case of infantile esotropia. Okay? Yeah, infantile eso. So answer would be D. This is our answer. Yes. Not acquired or congenital, दोनों नहीं हो सकता. It's secondary. Yes, it is secondary. So this is your infantile. Okay, 2 questions on infantile before I move to the next one. I will discuss here only. Before I go to this slide, my question is infantile esotropia. 2 important questions. Let's revise it quickly, all of you. I think I mentioned it. First important is latent nystagmus. Don't forget this. It's a feature of infantile esotropia. Latent nystagmus. And then I have written this as latent. Okay. Okay. Secondly, what is the next one? DVD, dissociated vertical divergence. ये क्या होता है? One eye will go up and then come down. It's a neurological disorder. It's a feature of when you cover one eye. When you cover one eye, the other eye can just go up, out and come back. This is called dissociated vertical divergence. You just have to know it's a feature of infantile esotropia. That's it. And you have to know this. These are your questions of AIMS. Okay, INI-CET के questions हैं, इसलिए ध्यान रखो. DVD, keep in mind, is a condition which will not obey Herring's law. ठीक है? It will not obey Herring's law. चलो, now I come to this slide. Avinash, what happened? Acha, all of you, First of all, listen to me. Whatever is not understood, you can just ask me separately. I will again in detail and make you understand. But at present, it's my responsibility to cover the slides. Okay? Come on, Avinash. It's not like this. It's all upon us. It is all in the mind. Keep fighting. Keep fighting. Keep learning now. You never know, the last thing that you have studied and the last point you have studied comes in the exam and you answer it. Okay? So come on, buck up. Give a smile. Yes. Now focus. Let's come back to the next slide. All of you. What is this? चलो चलो ये बताओ. वो मैंने रब कर दिया. आप बताओ ये. So this is your exam question, guys, that what is the ideal tonometer for a child, for the infant. So what are we using here is a tono pen. So tonometer for choice and for infants we will answer tono pen, and earlier we used to answer was Perkins. Perkins was handheld version of Goldman. So Perkins can also be used, was used in children, but now we will answer tono pen. Okay? So because tonometer questions are asked a lot, we answer this. This one, what are you looking at is, all of you, chalo Avinash tum answer, aap answer karo. Avinash, answer me this one. Chalo chalo chalo. Keep fighting, keep fighting, keep fighting, never give up. Don't disrespect yourself by ever giving up. Come on. What is the answer, Avinash? Chalo batao jaldi se. What are you looking at? Which type of tonometer? I am looking at your answer. Yes, very good, Nitish. We can use it in bedridden patients. Okay, Nitish, if you want me to add here one more point, tono pen can be also used for scarred and irregular corneas. Let's not forget that, scarred irregular corneas. Okay? This is another point, Nitish. You can keep it in mind for tono pen. Okay, this is Avinash. Where is Avinash? No, Arif, you are also famous. Don't worry. Nobody is answering me. You all are talking to each other. Shruti, what is this? This is no answer. But tell me which is the specific answer for this. Which type of tonometer? You are stabilizing it on your forehead. Any tonometer where you are stabilizing on the forehead. Self measurement. So it's a rebound tonometer. And this was again your AIMS question. The answer was this is used for self measurement. So you can measure it for your own eye. Okay. So this is what you are looking at. So whenever you see something stabilizing with the forehead, we are talking about rebound. Okay. Then what are you now looking at? Dhyan se dekho. This time I am going through the lids. I am not going directly through on the cornea. So this is transpalpebral tonometer. है ना? So transpalpebral tonometer is also, this one is diaton. इसका क्या नाम है? Diaton. ठीक है? Suppose the patient is a patient of keratoprosthesis. So go for this one. Got it? Yeah. चलो next पढ़ते हैं. What are you now looking at? Can you answer me this one, all of you? I am going to wait for your answer. What is this type of tonometer? Quickly. Okay, so wake up, Sid. Huh? This is, Arif is the only one who has answered correctly. So now Arif, you are going to be famous. So what is this? Okay, you all are answering Goldman. Where is Goldman? This is Goldman tonometer. And this was your exam slide again for the INI-CET. So ye hai Goldman, where you see two semicircles. You remember I took it in detail in the list. So this is your Goldman. क्या पढ़ा था? Goldman, what is the disadvantage? Though it is one of the gold standard, that reading of Goldman depends on the central corneal thickness. We will not forget this. For a thick cornea, we overestimate the IOP, and for a thin cornea, we underestimate the IOP. So now what were you looking at here? This is your Pascal's DCT. पहचान लो मैं हूँ कौन, isn't it? So this is your Pascal's DCT. Very good. Yes, that was Pascal's rather. Correct. Sadev is also correct. कोई बात नहीं वैष्णवी, now you will not make this mistake. So that was the purpose of discussion here. ठीक है? So this is Pascal's DCT is dynamic contour tonometer. What is one advantage of Pascal's here? The reading does not depend on CCT, so it is even better than Goldman. The reading does not depend on the central corneal thickness. ठीक है? No, you know Pihu, abhi bhi this is a very controversial question because this is a new tonometer, very latest one, but abhi bhi at all these centers the gold standard is still Goldman. If I go to a very good eye center and get even mind checkup, it will be done through Goldman, so it is not that commonly used. It is a new thing, it is coming. Okay? So whenever they ask you the gold standard, we will answer Goldman only. Okay, you want to see all photos of tonometer? Okay, very quickly for you all. ये लो नीतीश, ये हो गया आपका टोनो पेन. This was your Perkins, right? This was your rebound. This is transpalpebral diaton, ये वाला, and ये Pascal's. And what is this? We haven't come to this one. Ocular response analyzer is a non-contact latest one. Pascal was contact type latest one. Please remember. Okay? Okay, a very important exam question for you all asked again in this exam is, it is based on which principle? So we are taking the applanation reading not only when the corneas get applanating in, but also when it is applanating out. Just remember this term, don't take stress, it is corneal hysteresis. It is based on corneal hysteresis. ये नाम याद रख लेना. ठीक है? Okay. And what were the other non-contact tonometers? I hope you all remember air puff, pulsar. ये भी है ना? Pulsar and air puff. No Sadev, let's not complicate into corneal curvature. It takes the dynamic contour, it takes the contour of the cornea in a more accurate manner and it calculates the IOP. We will not learn this, that it is affected by any curvature. Okay, that is just the mechanism of its measurement. हो गया? I want all of you Bhavika to sit with a copy and a pen and write. I hope you all are alert and on the desk. Please. You all don't take this, but this is very, very important that you write through your own hand, your own way, and that when you will revise, you are going to retain. So please be serious. Don't just sit on the sofa and listen to me and then say, मुझे ये share कर देना, वो share कर देना. Please be alert. ठीक है? चलो. Let's learn together. Okay, this was what? This is your Goldman. ठीक है ना? ये वाला हो गया? Clear है? Okay, we come to this one. What is this slide? We are talking about the fundus changes. Can you see so many fundus changes we can see here? Question number 1 for you all. What is the normal CD ratio? What is the normal CD ratio? And when do we suspect it as glaucoma? When to suspect? On what CD ratio I should suspect? Tell me. Normal, whenever they are going to ask, less than equal to 0.3 should be the answer. Suspect, somewhere it is written 0.6, somewhere it is written 0.7. In the latest edition of Kansky it says 0.7. Okay. So then if a patient has a CD ratio of this much, we have to be very, very alert and we should suspect. So these are two different questions. I want you to appreciate what they are asking and answer accordingly. ठीक है? Bhavika, बताओ बच्चे. What are you looking? What is lamina dot sign? It is the visible opening of lamina cribosa. ठीक है? So this is what you are looking at. This is your lamina dot sign. Can you tell me what else we are looking at? Look here. This is shifting. This is nasal shifting of vessels. We can see the nasal shifting of vessels. And what is that sharp kinking known as? Don't forget, bio-knitting sign. Bending, double bending or sharp kinking is bio-knitting sign. Okay, coming to what are you now looking? What is the field effect here? We are talking about inferior arcuate scotoma. This is inferior arcuate I can look at. Very good, Tenzin. Correct. Yeah. Then we talk about, at this point actually I included this slide so that I am reminded of telling you your question is, which is the first visual field defect in primary open angle glaucoma? What will you answer? First visual field defect में क्या answer करना है? All of you answer me this because it's a very important question. I will not answer, you will answer. चलो बताओ. First visual field defect, what will you answer? Nitish, what have you written? I am not able to understand. Can you explain it? I didn't get it. All of you, I want answers from all of you. Now this again needs some mention here. Please listen to me, pay attention, look at me here. First field defect in glaucoma is not isopter contraction. It is paracentral scotoma in Jerem's area. Now there is a time restriction, I cannot go into too much detail to explain you, but you have to understand that isopter contraction is only charted in very special situations. What should be the standard target size when you are doing a perimetry? 5 mm. In isopter contraction it is only 2 mm. Okay, and you learn like this. First visual field defect, you can say central or paracentral scotoma in Jerem's area. Scotoma in Jerem's. Everybody knows Jerem area is area corresponding to arcuate fibers. You can call first visual field change as isopter contraction, but they have never asked you that. Okay? Will you all correct yourself now? Yes. Jerem's area is very, very important and you should know this. Okay. And one more thing before I go to the next slide. Which is the last island of vision which is left behind? Answer me this as well quickly. Last island of vision. Jaldi batao, jaldi batao. Okay, so these details of visual field defect have again been taken in the NEET PG session. I would like you all to please go through the session very thoroughly, and when you are combining today's session and that session, your more than 90% or 95% of ophtha will be revised nicely if you have studied from before, right? So please have a look at that also. Okay, I have told the field defects in detail there. I think so. Yes, I have told. Yeah. Okay. So batao, what is the last? Very good, Arif. Very well answered. So last is temporal island of vision. Yes, Pihu, this is easy one. Temporal island of vision is left behind. Okay. What are you looking at now? This is your rubeosis iridis, which can lead to what type of glaucoma? Neovascular glaucoma. Okay. So rubeosis iridis is leading to neovascular glaucoma. Okay. So neovascular glaucoma exam question, what is the treatment of choice? We will answer PRP. Okay. Pan-retinal photocoagulation. So that is the question around neovascular glaucoma. Always answer pan-retinal photocoagulation. Okay, we come to the next one. What are you now looking at? Pihu, if you will, Pihu, I am talking about when we were doing a revision session for the NEET PG, na? Just follow your Prepladder YouTube channel and you will get my sessions. Where before your NEET PG, the revision session which I had taken, actually it was intended to be taken in 2 parts, but it became 3 parts because of some technical issues. So it is part 1, 2, 3. Please, I am talking about that, Pihu. Okay. So I want you to have a look at that because that was in a different way and a more detailed. So no use speaking the same thing again and again. So we are now more image based. Okay, very good. Can you tell me what is the name of the sign? Avantika, Jitin, sign ka naam batao. That is more question oriented view. Have a look at that later. Abhi pad lete hain. What is the name of the sign? This is called Hoarfrost sign. Hoarfrost sign. Okay. So what is this actually? Why do you call it pseudo? One of you had asked me. It is not a true exfoliation. It is secretion of proteinaceous material and it is all deposited primarily on the suspensory ligaments and on the anterior lens capsule. Okay. So this is what is pseudo. And what is the next question they have asked you? Pseudo exfoliation, this dandruff like material blocking the trabecular meshwork. So, it is secondary open angle glaucoma, and very important question, it is the most common secondary glaucoma. Let us not forget this, it is the most common secondary glaucoma. Chalo, next we talk about, Nitesh, I doubt about this term, please check it again. What are you now looking at? This is so much light passing through the part of the iris because of the pigment dispersion. Now the pigments are not there to block the light. This is what is trans-illumination defect. This is your trans-illumination defect. And where do you see it, all of you? We are talking about pigmentary glaucoma. Padha tha na, pigmentary glaucoma is also called reverse glaucoma, where the iris is concave, rubbing with the suspensory ligament, release of pigments, blocking the trabecular meshwork. Generally seen in a young myope, he is coming from gym or exercising, and he can get a lot of dispersion of pigments and acute rise of pressure, discomfort in the eye, pain in the eye, and so on. This is how the patient will present. Done? Okay. So, we will remember pigmentary glaucoma, which is again a secondary open angle. It is also called, what did we learn? Reverse glaucoma. And what is inverse glaucoma before I go to the next slide? Malignant. Malignant glaucoma, do you all remember kya padha tha? Aqueous is sequestered in the vitreous cavity, leading to very shallow anterior chamber, right? So, it is not responding to anti-glaucoma drugs, therefore you call it malignant. Malignancy here means stubborn to treatment. ठीक है? तो ये हो गया आपका malignant. उसको क्या बोलते हैं? Inverse glaucoma. That is inverse glaucoma. Why do you call it inverse? Because we treat it with a mydriatic, with atropine. है ना? Normally glaucoma is treated with pilocarpine, but here we are treating it with a mydriatic. That's why we call it inverse. Chalo, we come to the next. So, now this one you all will answer me. What are you looking at? What is the diagnosis? Very, very quickly tell me. Here you are. What is the diagnosis? Dark night, what do you mean by with cycloplegic? Atropine itself is the strongest cycloplegic, isn't it? जितेन तुमने आपने लिखा क्या है ये? It is cornea verticillata. Okay, very good. So, or we call it vortex keratopathy or cornea verticillata. My next question for you all: what are the drugs which can lead to vortex keratopathy? I am not writing, I am just speaking. Chloroquine, amiodarone, indomethacin. Then in Fabry's disease, है ना, tamoxifen. Now a question for you all: which anti-glaucoma leads to vortex keratopathy? ये आप आंसर करोगे quickly, all of you. Which anti-glaucoma can lead to vortex keratopathy? Very nice, perfect. So, we are talking about nitarsodil. Okay, what is the mechanism of action? It is a new anti-glaucoma drug which is a RHO kinase inhibitor. It increases the trabecular outflow. We will not forget this. Okay, it increases trabecular outflow. Which was the other drug you have learned which increases trabecular outflow, all of you? Pilocarpine. ठीक है, याद रखना. What are you now looking at? This is your superior arcuate scotoma. And superior arcuate scotoma is also called Jerum's scotoma. इसका दूसरा नाम है, it is also called, the other name is Jerum's scotoma. Again we have learned this in our glaucoma field defects. Come to the next slide. Okay, we have a question here. So many times this has been repeated that I had to again discuss this. A 55 years old patient complaining of decreased distant vision. However, now he does not require his near glass. He does not require his near glass for near work. We are talking about, again very quickly, I have discussed in the previous session also. Second sight of old age. Second sight means it is, we are talking about nuclear cataract, isn't it? Very good. So, we all have learned this, that any nuclear sclerosis will increase the refractive index of the lens, and when the index is more, power is more, so I need lesser power on my specs, lesser power or no power, है ना. This is what is your second side. Generally it is more seen in old age, though 55 years is not a, we can't consider it that old age, but ठीक है, this is the term they have given. So, second side of old age you will answer nuclear cataract, where there is more power. जब हम कहते हैं more power, it means you are moving towards more power is what is called myopic shift. When you are moving towards lesser power, it is hypermetropic shift. So, what is happening here? Myopic shift due to increased refractive index of the lens. क्यों बढ़ा? Increase in refractive index is happening because of sclerosis. So, what? Sclerosis is hardening of the nucleus, that is why refractive index increases. Why it is hardening? Because of increased amount of insoluble proteins and lesser soluble protein in the lens. Clear? Crystal clear? Good. So, that was about your nuclear cataract. Okay, what are the questions on what is cuneiform? Let us see a few slides more. What is this? Everybody knows this is your, I am not going to ask, I know you know it. Morgagnian cataract. Exam question, most common complication. I think this was a post also in the Insta recently. Most common complication we will answer phacolytic glaucoma. It is phacolytic glaucoma, right? Then we talk about next. What are you now looking at? See, this is the corneal slit section, this is the lens section. We are looking at the nuclear cataract. What are the points to remember? One we have already discussed. Second point, if it is that this will be mainly affecting the day vision, because at the daytime the pupil is constricted. Okay, what is the most common complication of hypermature nuclear sclerotic cataract? Nuclear sclerotic, what is the most common complication? I want the answer. Very good, already given. It is subluxation of lens. Okay, Nitish, what is the most common cause of subluxation of lens? Batao, most common cause. Most common cause of subluxation of lens. Very good. So, very well, you are doing very well. So, this is trauma. Most common cause, trauma. What are we now looking at? What is this? This is your posterior subcapsular, don't call it Christmas tree, ध्यान से देखो, this is posterior subcapsular cataract, ठीक है, पीछे की तरफ है. So, posterior subcapsular cataract. What are the questions asked? Revising with you all. This is the cataract with maximum diminution of vision, causes maximum division. Why? Because it is near the nodal point of the eye. दूसरा सवाल. Tell me next one. Next you have to know, it is the most common type of complicated cataract, ठीक है, and it is also the most common type of radiational cataract. So, we will not forget all these things about PSC, right. What is this? This is what is cuneiform cataract or radial spokes, cuneiform cataract. Again we are talking about immature senile cataract. Chalo, again I am writing here, this is A, this is B, this is C, this is D and this is E. Recently asked question, I am trying to make this absolutely clear, no confusion, focus. Pick the odd one out. एक एक करके देखो. Where is the swelling here? Can you appreciate? This is the swelling. ठीक है? Okay. In this one, this is the thing. Okay. What about this one? Here is the swelling. This is very obvious, and here it is this. All of you answer me, which is the odd one? Which one is the odd one, all of you? Among all these pictures, which one is the odd one? I'll wait for the answer. Okay. Yes, now I am getting correct answers. Very good. So all of you, this is B is what is your limbal dermoid. Pehchan lo. Okay. So B is your limbal dermoid. When I talk about dermolipoma or lipodermoid, these are the different types. It is mainly on the temporal fornix here. Okay. In this case, again this is the one. Again this is dermolipoma and this is also lipodermoid or dermolipoma. This can also be a dermolipoma. Got it? So this is only with no fat tissue. This is just a limbal dermoid. Is it now clear? So I think on all this research, I think in our recall where we discussed about what is the diagnosis, I am going to put it in the Insta also. I think we should go for limbal dermoid in that case if we were looking at the hairs and all. Okay? Then the answer should have been limbal dermoid, not dermolipoma. But anyway, what is the difference? I told you, as you can see here in dermolipoma or lipodermoid, what you see, it is more on the temporal fornix. It can be connected to the orbital fat, it may be connected there. Both are choristomas and both may be associated with golden hair syndrome. Now another difference, generally a limbal dermoid, note it down please, can invade the cornea and involve the cornea, but these lipomas, dermolipomas, they are generally not involving the cornea. I had explained that earlier also. But now I think the answer of that question for the NEET PG there, if this was the picture with the hair and all, it should be limbal dermoid. Okay? Correct? So again, nobody was able to tell us now what is the correct picture, so this commotion and confusion is there. So that was still standing. But so many pictures after looking that, I think now we are not confused at all. Right? Yeah, Avinash, that's what we are talking about. So we had a discussion on it as well. Na? Okay, so now Avinash, what are you looking at here is mainly, now I have not given a typical picture of cobblestone, but it is a cobblestone with giant papillary hyperplasia and mucus deposition. So it is a pseudomembrane of mucus deposition on this papillary hyperplasia. Okay. So this is what is Maxwell-Lewin sign. Actually this is what is Maxwell-Lewin sign, which is a pseudomembrane over the or mucoid deposition over the cobblestone appearance. What is cobblestone appearance? We all know that it is papillary hyperplasia. Acha, iske baad, I hope you all remember the questions that when you talk about vernal keratoconjunctivitis, it is mainly in the summers, it is male children, and very important exogenous allergies. I am giving a quick revision here. So focus, and if you want to write down. What are the questions asked? Questions, no follicular reaction in this condition. Number 1 question, no follicular reaction. Number 2 question, ropey discharge. Number 3, cobblestone appearance. And number 4, what type of hypersensitivity? It is type 1 hypersensitivity reaction. We all know those Harner-Trenta spots kya hote hain? They are eosinophils. Okay? So that was a quick revision on VKC. Any child of VKC or maybe atopic keratoconjunctivitis or vernal keratoconjunctivitis, what are you looking out here? Can you see these folds? It is due to continuous rubbing and rubbing. These are called Denny Morgan folds. Okay, this is due to continuous rubbing. Now apart from this, too much of rubbing can, do you all remember, can also lead to keratoconus. You know? So that is why in VKC there can be a keratoconus due to too much of rubbing of the eyes. So we will keep these things in mind. Yes, Avantika, very nice. And yes, shield ulcer. Thank you for reminding. Shield ulcer is also a feature of vernal keratoconjunctivitis. What are you now looking at? I think we all know we are looking at Bitot spot. Okay? What are the questions asked? I have talked about what is primary sign, secondary sign in my earlier session. Bitot spot is more common on which side? We will answer temporally. Then they have asked you what is the earliest feature of vitamin A deficiency. We all know we will have to answer nyctalopia. I am asking you another interesting question, answer me this. So you know that vitamin A deficiency is causing xerophthalmia, that is quite easy. What was vitamin A toxicity leading to in the eye? What did we learn? I will wait for the answer. Vitamin A toxicity batao. Okay, I'll go to the next slide while I'm waiting. Perfect PU. So that causes benign intracranial hypertension, that is pseudotumor cerebri. Will not forget that. Well answered. Chalo, we come to the next slide. Ye batao. This is what? We all know this is a tear strip. And what we do here is a Sturmer's test. Anything less than 5 is a severe dry eye. Anything less than 5 is a severe dry eye. And if you want to do it for a quickly, you don't want to wait for 5 minutes keeping the strip there. For 15 seconds only you have to keep. This is your phenol red thread test. This was your again AIMS question. That's why I have put this slide here. So this is your phenol red thread test. When you say phenol red thread test, all of you all know na, the thread is coated with the phenol red, change of the pH will change the color. We have to wait for only 15 seconds. Anything less than 9 mm is dry eye, significant dry eye, right? So don't forget this one. Yes, we are talking about keratoconjunctivitis sicca. Okay, so many questions on this one. This is your, you all know, pterygium. Let me ask the questions. All of you tie your seat belts. Answer this quickly. Is it an inflammatory or degenerative disorder? Number 1 question. It is more common on which side? Which ultraviolet rays is responsible? How do we differentiate between pterygium and pseudopterygium? Keep answering. Yes, it's a connective tissue disorder or degenerative. So when you learn in the detail, what you will learn? It is elastotic degeneration of conjunctival stroma. We'll remember this, they have asked. And the same thing is also happening for pingicula. Pingicula has no fat, keep in mind. And the same thing is happening for pingicula, elastotic degeneration of conjunctival stroma. Okay? Chalo, more common on which side? I am still waiting. More common nasally, very good. So remember this one nasally. Pingicula also nasally. Ultraviolet ray, which one? Roy the old gamer, your answer is wrong, game garbad ho gaya. Huh? So it is UVB rays. ठीक है बच्चे? Write it down, it is UVB rays. My next question, UVB causes what other condition in the eye? Apart from this. UVB can cause what other condition in the eye? चलिए जल्दी बताओ. I'll wait for the answer. How do we differentiate pterygium from pseudopterygium? Glass rod test. If it does not pass, it is pterygium. If it passes easily, it is pseudopterygium. Please don't learn the reverse. If it is passing easily, pseudopterygium is nothing but any scar tissue which is adhered only at the apex, so glass rod can pass easily. ठीक है? चलो. So these are the questions we have to know, and I hope I think I have mentioned in the earlier session, revise kar lena what was perfect surgery. So what is the best method of preventing recurrences? Autografting, and extended autografting is what is called perfect surgery. So we have to know everything in and around pterygium, it is asked. ये क्या हो गया? What was my question and what are you all answering here? Very good. Yes, Roy. So we will say it passes easily in pseudopterygium. ठीक है? So that was the question. These are the questions we have to remember. And one question I told you that you should know what is perfect surgery, which is extended autografting, isn't it? Pterygium extended resection followed by extended conjunctival transplantation. चलो ठीक है. अब हम next पढ़ते हैं. Come to this one question. Again I put here, this is A, this is B, this is C, this is D. All of you, see seriously, what are we looking at? Chronic blepharitis leads to all except. Chronic blepharitis leads to all except. What is this? What is A? ध्यान से देखो, what is A? The two arrows. And what is C? And what is this? D. So, बताओ. Okay. So can we see this, realize this is madarosis, loss of eyelashes? A is madarosis. Thickening of eyelids, this is stylosis you are looking at. Then you are looking, graying of eyelashes is called poliosis. This is what you are looking at. है ना? Very good. And no, you all are not answering. C is not the answer. Yeah, B is the answer. What is B? What is B? Double row of eyelash. This is also your exam slide. So you have to remember this. This is dystichiasis. Okay? Dystichiasis or double row of eyelash. So this is just a congenital thing. This is not after chronic blepharitis. So we have revised through this question. What is amadrosis? You all remember it is also loss of eyebrow. Loss of eyebrow के cause क्या पढ़े थे? Leprosy and myxedema. चलो. Should I ask one more question before going to the next slide? Will you all answer? Poliosis, which syndrome do you learn? Poliosis occurs in which syndrome? Poliosis. Double row, not multiple row, Roy. Double row. उससे ज़्यादा की गुंजाइश नहीं है. There is only, it's already anterior to your grey line. We have the normal eyelashes. The only space is your posterior. So it is double row of eyelash. ठीक है? Perfect, Jitin. Wardenberg, can you remember one more? Apart from Wardenberg, one more dark night? Why dark night? Why not morning sun? Why not bright sun? Keep some positive names if you all want to keep. Very good. Yes. Bashrat is answered correctly. This is VKH. So we will remember this. Two syndromes. Note it down. Wardenberg syndrome and Vogt-Koyanagi-Harada syndrome. ठीक है? चलो next पढ़ते हैं. What is this? It's already written. Now what I want you all to revise here, while we say it is a simple congenital ptosis, can you see there is absent lid crease? Why there is absent lid crease? Very easy reason. LPS is not formed properly. It is the LPS attachment to the skin which is forming the crease, so I don't get a crease. ठीक है? And what else? Don't forget, this was important question, lid lag on ptotic side. You have to remember this. This is a feature of congenital ptosis. Do you understand what it means? So normally, if these are the two lids, suppose these are the two lids. अब हम कहते हैं this is ptotic lid. ठीक है? So when you ask the patient to look up, this will go up, this cannot go up. But when you ask the patient to look down, this goes more down than even this. Ptotic lid में there is lid lag. So this goes more down and this is down. Why? Because when LPS is defective, it is not only contraction but relaxation of LPS is also defective. And that is why you get a lid lag on ptotic side. Okay? So this is very, very important. Muscles are not absent, Roy. They are not properly formed. And muscles में कौन सी muscles? We are talking about levator palpebral superioris. Right? So chalo, we come to the next slide. Okay, the horizontal, I am giving you the hint, the horizontal length of this lid is less. There is ptosis and I can see extra fold of skin which is coming from the lower lid. This is epicanthus inversus. Can you name the syndrome, all of you? And the distance between two medial canthus is more, that means there is telecanthus. Again, this was your AIMS question. What is the difference between telecanthus and hypertelorism? I had referred this in the last session also. Telecanthus, the interpupillary distance is normal. Hypertelorism is a bony defect, interpupillary distance is more. So here this is telecanthus. Tell me the name of the syndrome here, all of you. Now you are tired, huh? Quickly, tell me the name of the syndrome. Baba re. No, it's not a blue sclera here. उसकी आँखें ऐसी हैं, Roy. We are only giving you these features. Ptosis, less horizontal length, telecanthus, epicanthus inversus. I will wait for the answer. I don't think I should be answering this. You all have to know this. Thank God, Devesh has answered finally. Anyone else? It is blepharophimosis syndrome. Okay, we are talking about blepharophimosis syndrome. You remember this? Yeah. Okay, very good. We come to this one. What are you now looking at? This is trichiasis. What is trichiasis? Misdirection of eyelashes, trichiasis. It is the misdirection of eyelash. And what is pseudotrichiasis? किसको कहते हैं? Pseudotrichiasis. What is pseudotrichiasis? Tell me. When it is due to entropion, inward turning of the lid margin, then it is called pseudotrichiasis. Okay, this was your exam question. You are looking at what? Ankyloblepharon. What is ankyloblepharon? Adhesion of the two lids. Right? Okay. Here what do you see? This is bulbar and palpebral conjunctiva are adhered. What do you call this? Symblepharon. This is what is symblepharon. So, symblepharon you can get after any surgery, any burns, conjunctival sacratizing conditions of conjunctiva can be due to any type of burn, chemical, electrical, radiational, isn't it? Any ulcers in the conjunctiva and so on. Okay, that can lead to these scars, adhesions. Okay, here you should be absolutely clear. This is at the lid margin. We are talking of hordeolum externum, which is your stye. Externum is at the anterior lid margin. Hordeolum means swelling. So, you are looking at stye. Right? Okay. We come to the next one. This time it is on the tarsal plate and not in the margin. Please appreciate. This looks like a very inflamed with a pus point. So, I will call it hordeolum internum. But suppose it was a chronic granulomatous painless swelling on the lid. This is the lid, this is the lid margin. This is a simple diagram. So, any painless swelling on the lid now, which is, that is what is chalazion. You all know this? Chalazion. Asked many times. Repeated question, and the same question in this same exam, and said they have asked you, it is a chronic lipogranulomatous inflammation. बस ये याद रखना. ठीक है? So, chalazion is a chronic lipogranulomatous inflammation. I am writing here. Okay, can we move further? Chalo, we have some more interesting things to discuss. Come to this one. Of course, this embryonic development you all must have done. What is derived from what? Can you answer this one? Question suno. Ectodermal in origin is all except. Answer me. Ectodermal in origin is all except. What should be your answer? At present, no Avinash, not at present. You can find it in the any swelling which is painless. It is not a very big thing. Go to the Google image, you will get it. Okay? I don't have it at present. Forgotten पे हो? अच्छा ठीक है, सोचो. चलो साथ साथ पढ़ते हैं. लेंस क्या था? सरफेस एक्टोडर्म. ठीक है, ये पूछा गया. This has been your separate question. Learn with me. What about iris sphincter, dilator pupilli? These are the two muscles of the pupil, and your secondary and tertiary vitreous. All these are derived from neuroectoderm. Okay. So now what is left is your blood vessels. This was your from mesoderm. ठीक है. So, all the coverings of the eye, stroma of the cornea, endothelium of the cornea, choroid, okay, and all part of the sclera except the temporal part, they are all derived from neural crest. Okay? Those coverings are, that is from the neural crest. This is how you will remember. Okay. So, just revise it, they can ask you. We come to the next question. Now, when the question is like this, so this time I haven't put the options, but you will definitely be getting the options. So, whenever you get a long question, again my tip for you all is look quickly at the options. Look at the last two sentences and then go for some catch points. Then start reading the question quickly. Okay. So, a 40 years male patient presenting in the IOPD with complaints of diminution of vision, which is more prominent at the night. Achha. On examination is using specs. Specs to -7 hai. 6/12 right eye and 6/2 in the left eye. Best corrected. That means he is little amblyopic. Anterior segment mein he is having posterior subcapsular cataract. Fundus examination Bilateral mid-peripheral bony spicule pigmentary changes with RP atrophy, arteriolar thinning, mild pale pallor disc, ERG showing reduced scotopic response. I think everybody can answer me what is the diagnosis. So, there are bony spicules, attenuation of arteries, pale disc, ERG is diminished. We are talking about retinitis pigmentosa, isn't it? So, the white arrow is showing you your bony spicules which are pigmentary disturbance. This is your pale waxy disc, okay, and attenuation blue line, this one, this attenuated artery, okay, attenuation of arteries. Very good. Okay. So, the ERG response in retinitis pigmentosa is something like this. I think everybody remembers ERG as A wave and B wave. This was your very important exam question. A wave corresponds to what? Recent. Again this AIMS question. A is your rods and cones, don't forget. And B wave is B for B, bipolar cells. We will remember this only. C is a very small for RP, but we do not look at C, we look only at A and B. ठीक है? अब ये भी याद कर लो, what is the most common systemic association of RP? All the questions on RP please. Most common systemic association, we will answer Usher's syndrome. Usher's is RP with deafness. RP with deafness. ठीक है? And of course we know there is no effective treatment, right? Some latest things which are going around is like docosahexaenoic acid can slow the progress. This was asked once in your exam, so we have started telling you this. May slow, it is not 100% proved, it may slow the progress. It is a normal constituent of your rod's outer segment. So, it may slow the progress. Okay? Yeah. And of course, about retinal implants, right, like, so is the last resort, it is very costly and not commonly done, of course not in India. Okay? So, that was about your RP. Any question we are leaving in RP? Yes. What is the early, this is very important, what is the early field effect in RP? Because RP is a disease of mid periphery, the early field effect you will answer is ring scotoma, है ना? सबसे पहले क्या होता है? Ring scotoma and late, so this is your ring scotoma and then when it progresses, it like this, only a small field is left behind, this is what is tunnel vision. So, late stage tunnel vision, early stage ring scotoma. Okay. So, these are important questions on RP. Very good. Avantika, and okay, many of you are answering good. Tell me what are the drugs which can lead to tunnel vision or constriction of visual field? I want you to remember 2 drugs. बताओ क्या क्या था? Which can lead to constriction of visual field? Do you remember? Quickly, quickly, quickly. Very good, vigabatrin, and second also remember quinine. Vigabatrin was again your AIMS question and दूसरा याद रख लो quinine, okay, quinine, very good. We come to the next one. Here what are you looking at? This was also your exam question, again of this exam only. So what are you looking at? Okay, I see the dye at the choroid, the background is all dark, I cannot see the choroid fluorescence. This is due to heavy deposition of lipofuscin. Yes, we are looking at dark choroid sign. Dark choroid sign, or we also call it silent choroid. Yes, very good Tenzin. We also call it silent choroid. Which condition? Where do you get this dark choroid or silent choroid? In which condition, all of you? No, this is not CME, this is not flower petal. Not at all. Very good Devesh, it is Stargardt's disease. I have discussed this later also, earlier also I mean to say. So, this is Stargardt's disease. Okay. So, revise it all of you. And what is this? I can't see any dye in the blood vessel, but I think so many shiny things. This is lipofuscin which has a quality of autofluorescence. So, this time it is not FFA, it is FAF, fluorescein autofluorescence. Again you are looking at Stargardt's disease. So you have to see, is there a dye in the blood vessel? If it is, then it is not, otherwise it is a, or then it is a fluorescein and is in the dye, then please it is a fluorescein angiography. If not, then it is autofluorescence. Okay? Okay. And what is this? What are you looking at? I hope you all remember, this is your egg yolk appearance. Egg yolk appearance, we are talking about Best disease or Best vitelliform dystrophy. Okay, a very important exam question on Best diseases. What is the value of Arden ratio? Everybody remembers Arden ratio? Light peak upon dark trough is what is electrooculogram, which is the choice of investigation, and light ratio of light peak upon dark trough. What is this? Normal it is what? Normal it is more than 1.85, isn't it? More normal is, very good Devesh, normal it is more than 1.85 equal to, and in Best disease it goes, in Best vitelliform it is less than 1.5. Acha, ek aur question they had asked you again in this exam only, what do you mean by flat EOG? Kya bologe? What is flat EOG? Devesh answer karo. What is flat EOG? Flat EOG batao. Fatafat, fatafat. We have to go to the next one. Flat EOG means when the Arden ratio is less than 1.25. Please remember. Okay? When it is less than 1.25. And what are you looking at here? Beaten bronze appearance. So this is a beaten bronze appearance of Stargardt's. Isn't it? Stargardt's. Please remember, I have told you Stargardt's we avoid vitamin A. We don't give, ऐसे vitamin A हर जगह चल जाता है, but not in Stargardt's because it will promote lipofuscinosis. So avoid vitamin A. Okay? Okay, what are you now looking at? What is this? Of course, it's a tumor inside. This is a retinoblastoma seen on the ultrasound B scan. Simple, isn't it? Okay. Two questions here. What is the investigation of choice of retinoblastoma? Then you will answer MRI. What is the first investigation through which we generally commonly in practice diagnose retinoblastoma? First is always ultrasound B scan. So these are the two questions. Okay. Then we talk about this question. Let's see, read it. Okay, again we are talking about a 45-year-old male patient, gradual blurring, diminution of vision in his right eye. Achha, theek hai. Examination, this is the vision. Right eye mein it is very red, 6/24 only, left eye is normal. Slit lamp examination is showing heterochromia iridis. Cornea has stellate KPs, mild flare, all of you, atrophic patches in the iris with posterior subcapsular cataract. What are you talking about? Stellate KPs, heterochromia iridis, HI with stellate KPs, है ना? And iris atrophy. Make the diagram, you will never forget. Because of this, no posterior synechia, but of course there can be posterior subcapsular cataract, very common. No synechia but posterior subcapsular cataract. What are we talking about? But we have posterior subcapsular cataract. This is your Fuchs heterochromic cyclitis. So you are looking at Fuchs heterochromic cyclitis. See, this is the iris atrophy. Okay? Yeah. What else they have asked you? Bleeding after paracentesis, bleeding at the angle that is seen on gonioscopy. This is what is Amsler's sign. So this has been your exam question. What is Amsler's sign? Very nice. Yes, many of you are answering correctly. रॉय, ये तो बहुत ब्रॉड आंसर हो गया, थोड़ा और पढ़ाई करनी पड़ेगी, है ना? It is Fuchs heterochromic cyclitis. Which uveitis? You should know which uveitis. ठीक है? Yeah, and why are you getting Amsler signs? Because of the blood vessels in the angle. Okay, radial blood vessels, exposed blood vessels in the angle. Okay. Now what are you looking at, Roy? Now this you can say that okay, these are KPs which are so prominent and big, which is these are what are called mutton fat KPs. Mutton fat KPs, okay, is a feature of all of you, granulomatous, anterior uveitis. Now we can answer anterior uveitis. What is that imaginary triangular area where the KPs are maximum? This is what we call arch triangle. है ना? Arch line कहाँ पढ़ा था? Trachoma. Remember, two ही arcs हैं. One is arch triangle and one is arch line. Very good. We come to the next one, and what are you looking at here? The arrows are telling you these are the points which are not moving in spite of dilating. These are the synechiae. Here you have one posterior synechiae here, you have one PS here, you have one PS here. That is why it is not moving. So, what is the shape of the pupil? Festoon shape. Exam question, this is what is festoon shaped pupil. Right? So, this is your festoon shaped pupil. Again, it is a feature of posterior synechiae. What are you now looking at? Very important exam question. ध्यान से देखो, what are you looking at? I can see the fundus picture. Can you see the disc? No. The disc is so small. See, here is the disc and the mag. If it is so small, that means I am looking through indirect ophthalmoscope where the magnification is very less. Therefore, I can't see the disc. But what I am more focused on is the periphery. What is this deposition? This is what is snow banking. Important question. It is a pathognomic feature of an intermediate uveitis. It is a pathognomic feature of intermediate uveitis. It is a pathognomic feature of intermediate uveitis. Very good Avantika, this is snow banking, correct. अब ये वाला बताओ, all of you, what is this? I think many of you can answer this one. Can you see along the veins what is happening? I'll leave it for you to answer this one. बताओ बताओ बताओ. No, this is what is candle wax drippings. Okay. So, candle wax drippings क्या थे? Thick venous sheathing of periphlebitis in sarcoidosis. So, we are looking at candle wax drippings, which is a feature of sarcoidosis, which is thick venous sheathing of periphlebitis. ठीक है? Any box carrying or segmental will not look like this. थोड़ा सा सोचा जाए तो, isn't it? Yes, very good. MS. What are you now looking at? Again, a very important slide where I see hemorrhage, I see necrosis. So, this becomes a sauce, this becomes the cheese. Sauce and cheese retinopathy. So, this is what is sauce and cheese retinopathy. So, it is a feature of all of you. What is the diagnosis? Quickly answer this. Very good. CMV retinitis. Most common opportunist infection after HIV is CMV retinitis. CMV. Okay, don't forget that. What are you now looking at? What is this? Headlight and fog appearance. Headlight and fog appearance. And these are the punched out lesions after the healing. What is the diagnosis, all of you? What is the diagnosis? Very good Avantika. This is your toxoplasmosis. We are talking about toxoplasmosis. Chalo ye batao. It's already labeled for you all. You are looking at Dalen-Fuchs nodules. What is the diagnosis? What is the diagnosis? What should I write here? Where do you see these granulomatous nodules? It is between, where are they present? This is the retina, this is your choroid, and what is the membrane between the two known as? The innermost layer of choroid is Bruch's membrane. So, these nodules, they are actually between the Bruch's membrane and the retina. These are what are called Dalen-Fuchs nodules. समझ आ गया? अब बताओ feature of. How come I am not getting this answer? It's very important. बताओ what is the diagnosis? Quickly. Diagnosis. What is this condition? Sympathetic ophthalmitis. We are talking about sympathetic ophthalmitis. Yes, very good Shruti. Shruti, what are the other questions? All of you, what are the other questions asked in sympathetic ophthalmitis? What is the first sign? We will remember retrolental flare. है ना? First sign, retrolental flare. Okay, what is the first symptom? It is behind the ciliary body, in the ciliary body area behind the lens. What is that area responsible for? It is mainly accommodation. Okay? So, what will you answer? The first symptom will be, आपको बोलना है, first symptom is difficulty in near vision. Okay, so we will say it is difficulty in near vision or decreased accommodation. Don't forget that. And which is the most dangerous area of the eye? Parson had given this term, this has been your exam question. Dangerous area of eye is ciliary body, as any trauma here can lead to sympathetic ophthalmitis. Chalo, we come to the next question. Let's talk about this one. Corneal edema occurs due to, now you have to identify more than one are correct in the statement. I am not giving you A, B, C, D. See, the question says, all types of questions I have put here. So, identify the correct options. S लगा हुआ है, ठीक है? Let's see. If this is what you are looking at is corneal edema, isn't it? It occurs due to, number 1, activation of anaerobic glycolysis or inhibition. What will you answer? A or B? Quickly, all of you. Activation of anaerobic or inhibition? Seen when IOP is raised or when IOP is low? Occurs due to endothelial dysfunction or epithelial dysfunction? Chalo, अब answer बताओ. What are the answers? It is A is one. What about the rest one? There are other options also, not only A. One is A. Okay, what is the other one? IOP raised or low? C or D? Which one? When IOP is raised. A, C. Very good. And very good. Yeah, Lovita. You have answered correctly. It is ACE. Yes, it is ACE. Answer is A, activation of anaerobic glycolysis. All of you, let me explain you this. When there is anaerobic glycolysis, very quickly I am telling you, if you want to write, you can write. What happens? Lactic acid production. उससे क्या हो रहा है? There will be metabolic acidosis. And when there is metabolic acidosis, what happens? That inhibits the sodium potassium ATPase pump, which is responsible for keeping the cornea dehydrated. That is why you are getting hydration or edema. So, you will always say activation. IOP जब raise होता है, again this happens. Why? Because the stromal pressure of the cornea, which is around 53 to 55, if IOP goes more than that, there will be edema. And is it due to endothelial dysfunction or epithelial? Of course, it is the endothelium which is responsible for this. I hope you all remember this endothelium is not only acting as a barrier so that aqueous doesn't come into the cornea, but whatever aqueous comes, it is pumping it out back into the aqueous. So, it is both pump function and barrier function of endothelial cells which are responsible to keep the cornea in a dehydrated state. हो गया? चलो. So, that was one important thing. अब आ जाओ बताओ what is this? This is very important. We frequently ask slide. Yes. What is this one? This is your, yes, simplex. What are you now looking at is dendritic ulcers. Tell me why it is dendritic. What is the main catch point? It has knobbed ends. Don't forget it has knobbed ends. They ask you this. And it's a feature of only simplex, not zoster. Common mistake. So, I am telling you. Dendritic ulcers are only a feature of simplex infection. And very, very important question, steroids are contraindicated in dendritic ulcer. Steroids are anyway contraindicated in any infective epithelial involvement. We are going to keep that in mind. Yes, awesome. क्या हुआ पीहू? What happened? Then what is this one? What are you looking at here? This is your, yeah, recent NEET PG question as well. Yes, Avinash. I am happy you are fighting, Avinash. So, coming to this one, what is this? Ring ulcer hai na? Ring ulcer of, they will give you the history and things around it, of course. So, we are talking about acanthamoeba keratitis. Okay, what are the questions? Pay attention, all of you. Most common infection after contact lens use. Don't answer acanthamoeba. They have asked you most common. What will you answer? It is your Pseudomonas. And acanthamoeba, mainly soft contact lens users are prone to get this rare infection, that is acanthamoeba keratitis. Okay? These two are two different facts. So acanthamoeba is rare infection, it is not common. Are we clear now? Number 1. Number 2 question क्या है? They have asked you about culture media of acanthamoeba. We all know non-nutrient agar with E. coli. Very factual, we can manage it. Third, what is the treatment of choice or drug of choice? We will answer PHMB, polyhexamethylene bigonide. Right? So, we will answer PHMB. Okay. Now, we talk about this next slide. Again, very important question. What are you looking at here? Calcium deposition in the shape of a band, because it is only this area which is exposed. वहीं पे होता है ना? Rest is covered with your lids, that interpalpebral strip. That is why this is called band shaped keratopathy. Right? So they have asked you, it occurs due to most common cause. They have asked you, it is idiopathic most commonly. We do not know why it has happened. And hope you remember the causes: chronic uveitis in patients of JRA, in children suffering from JRA. It can happen in thysis bulbi. And hypercalcemia, isn't it? So, any vitamin D toxicity can also lead to this. And there was exam question, because it is in hypercalcemia, it is also a feature of sarcoidosis. We will remember this, sarcoidosis. Done? So, these are the questions, and yes, they have also asked you about the treatment. So, what is the treatment of band shaped keratopathy? बहुत simple है, chelation with EDTA, isn't it? Chelation with EDTA. Very good, all of you answering correct. Nice. चलो आगे बढ़ते हैं. What are you now looking at? Seems everything normal. No, there is lipid deposition out here. This is what is arcus senilis. Very important question. Arcus senilis is lipid deposition where? In stroma. Please remember. Can you see this clear black strip? This is the lucid interval of Vogt, where the cornea is clear. Got it? Yeah. And what is, this is happening in old age, so senilis. What is juvenilis? When it is happening in the young age due to hyperlipidemia. Yaad rakhna. Okay, we come to this one. What is this? If I want you all to answer me this. What is this? Diagnosis. I'll wait for this. बताओ 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 ये क्या है? If you get a picture like this, what are you going to answer? What is this? I'm waiting. Bashra, triad, कौन सा triad? Roy, no. Okay, so this is a topic which is asked in this exam, INI-CET. बताओ क्या है ये? It's a type of dystrophy. So this map dot and fingerprint dystrophy, this is your microcystic dystrophy. We are talking about microcystic corneal dystrophy. Okay, so this is one of the most common corneal dystrophy overall is this one. You will revise this. None of you have answered correctly. Okay? Yeah. So dystrophies have been asked in exam. So if you remember a few questions, which is the least, I'll just have to, because of time crunch, I can only pick up few questions here, but do revise it. Least common corneal dystrophy overall, you will answer is macular. Macular is a stromal dystrophy. Macular, another question, it is associated with mucopolysaccharidosis. Keep noting down please. Mucopolysaccharidosis. They'll ask you just direct factual questions. Then macular is the only among all the corneal dystrophies which is autosomal recessive. Okay? And which is the most common stromal dystrophy? Overall most common was microcystic, but most common stromal microcystic is epithelial. ठीक है? So stromal में आ जाएगा lattice type 1. Lattice type 1. right? Okay. So, just revise your corneal dystrophies. Then I think there was one AIMS question on stain, that granular is stained by. So, granular is another stromal dystrophy where granular dystrophy will be stained by Mason trichome. This has been your PYQ, Mason trichome, just remember this. Very good, some people are answering, they have studied, very nice, yeah, okay, take care. So, we will revise this as well, take care. Yeah, Mason trichome. Okay, now we come to this one. Can you answer this question? It's interesting, simple, very simple question. All are associated with non-granulomatous anterior uveitis except. देखो क्या क्या लिखा है? Non-granulomatous anterior uveitis except. What will you answer? I expect you to answer this, so I am not answering. बताओ. Very good, very nice Avantika, it is rheumatoid arthritis. We all know that rheumatoid factor is absent in all the arthritis associated uveitis. Simple answer. Now Avantika, tell me what is the most common ocular feature of rheumatoid arthritis? Of rheumatoid arthritis, अब क्या बोलोगे? Most common ocular feature of rheumatoid बताओ. Fast. No, Jitin, we will answer yes, KCS, keratoconjunctivitis sicca. Okay, we will answer this. It can even lead to, you know, I'll tell you one interesting term here. Rheumatoid arthritis can cause corneal melting and lead to, ऐसा लगता है कि cornea पे you are wearing a contact lens because of the peripheral melting. We call it contact lens cornea. Just the term was very interesting, so I shared with you. But what they have asked you about is most common this feature of rheumatoid. Chalo, we come to the next one. Oh my God, again such a long question, huh? Chalo, let's read together. 35-year-old, we should always note this. This is important. All the time it helps. So he is a 35-year-old male. ठीक है? Blurry vision in the right since 1 week. The images in the right eye are distorted images. I think all of you have guessed already. So his symptoms several days after starting in he was using steroids for arthritis. Does it make any sense? There is no history of any photopsia or floater. That means, what is photopsia? Flash of light, and floaters are opacities in vitreous cavity. I expect you all to know this. Okay, chalo, फिर फटाफट ऐसा करते हैं. Instead of reading all this, we quickly come to what is on the fundus examination. Ring reflex at the foveal area. Amsler grid is showing central distortion. Tell me what is the diagnosis. Do I need to even read further? No. A young male with distortion of image and ring reflex, we are talking about CSR, and that too history of steroids. So, we all know steroids aggravate central serous retinopathy. Does it happen in females? One of, I had got this question on my wall. Can it happen in females? Yes. Actually, the ratio of male is to female here is 3:1. But generally, commonly at your level, we will learn that this is the disease of young males. Chalo, let's see what we have. So, this is the ring reflex of CSR. What else they ask in CSR? Please remember, acute onset, chronic. There are two types. And this has been an exam question. If it is an acute CSR, which will happening in since a very short while, it is generally seen to be self-limiting. We do not need to treat it. This is your exam question. Yes, Roy, oh, central serous retinopathy. Okay? Okay. Then this is the Amsler grid. What are you looking at? What do you call it? Metamorphopsia. Any distortion of images, metamorphopsia. What is the other condition where Amsler grid is very, very helpful? All of you? Which other condition the Amsler grid is very helpful? Siddharth, ये bullseye लग रहा है. Bullseye will be alternate area of hyper and hypo. And Siddharth, this whole history is not going towards bullseye. There is no history of chloroquine, hydroxychloroquine, anything. So I don't think we should ever get confused. So this is this image is in relation to this question. Have a look at a bullseye, you will understand. Bullseye is alternate area of hyper and hypo. Hyper, hypo. Okay, it looks something like this. No, this is not a very good thing to make. दोबारा बनाते हैं. Let me show you. It is alternate areas of. It is like this. Okay. Okay. We come to the which other condition? Nobody is answering me this one. No, the other condition for Amsler grid is ARMD, age-related macular degeneration. All of you, it is age-related macular degeneration where your Amsler grid is going to be very helpful in diagnosis. याद रहेगा? Okay. Any macular disease, the maculopathies. Navneet is correct. Any maculopathy you should say, not say optic nerve disease. Okay. Okay. We come to the next one. This is an OCT which is showing you that this is the subretinal space पे how the fluid is accumulated in CSR. It is only at the central foveal area, है ना? So this is what is CSR. Got it? So this is the OCT finding. You can get an OCT finding in the colored manner also, or you may get it like this also. And this one I think everybody will remember. So many times we have learned in CSR, this is ink blot pattern of leakage. This is ink blot pattern. And what is this? Oh, my arrow is little overlapping. It was something like this, and sorry for this. So this is your smokestack pattern. Smokestack pattern. We will not forget this. These are repeated questions. Ab batao, what are you looking at? You all were answering this previously. This is a fluorescein angiography which is showing you the, so see background you can see white, it is not dark. That was dark choroid sign. Here the leakage is in flower petal pattern. So this is what is flower petal pattern, and this is, that means we are talking about cystoid macular edema. Chalo, we come to the next slide. What are you looking at? What will you say? This is leukocoria. Okay. We all know leukocoria, we are learning in relation to retinoblastoma, but most common cause if they ask you, you should answer congenital cataract. Okay. And all the causes apart from retinoblastoma, what are they collectively known as? क्या बताया? Pseudogliomas, है ना? Okay, so this was a very recently asked question. What are you now looking at here is Flexner-Winter-Steiner, right? So these are the rosates with the central lumen and columnar cells. This is what is Flexner-Winter-Steiner. So this was your exam question. So I have included this, and when there is no lumen in between in the center, these are pseudo rosates. What do you also call that? Were rosates. These are pseudo rosates. We also call it Homer Wright. Yes, and these are fluorates. Right? Yeah. Now what this one we have done already, isn't it? Okay. We come to this question. Let's see what this question says. 22-year-old male presenting with progressive loss of vision, right more than left. On examination, right is 6/36, left is 6/12. Okay. Anterior segment examination is showing, this is so easy, clear ectatic cornea. Right eye mein vision less hai, and the right eye you see ectatic cornea with stria, iron deposition on the cornea, V-shaped deformity of the lower lid on down gaze. So what are we talking about? Even the pachymetry reading in this central thinning, so much less, and it is thinnest up to 360 microns. I hope you know the normal corneal thickness, 500 to 600 microns. है ना? So what are we talking about? Do I have to read further? So corneal topography showing myopia with irregular astigmatism. Yes, we are talking about keratoconus. Absolutely wonderful. So you all know. So keratoconus, few more things. So this is a case of keratoconus. These are, you all know, break in the Descemet's membrane which is seen vertical. So Vogt stria are like this. What was Hab stria? That is in the congenital glaucoma, they are more circular. So these are Hab stria, and this is what is Vogt stria of keratoconus. This is what we will know as Munson sign, V-shaped deformity of the lower lid on looking down. ये क्या दिख रहा है, देखो ये देखो, येलो एरोज, फ्लेशर्स रिंग, iron deposition. Where is the iron deposited? Epithelium, Flesher's ring. What was case of Flesher? So many times we have discussed. Copper deposition in Descemet's membrane in calcosis, है ना? Okay. Then we talk about this question. चलो बताओ, which muscle is responsible for the ocular movement marked in the image? So this is what you have to answer. What do you see here? These are the 9 gazes, isn't it? Okay. So when you talk about the 9 gaze, this becomes the primary gaze. What is this? Elevation, depression. है ना? What is this? This is your her right eye, so this becomes dextro elevation. This is dextroversion, looking straight to the right. This becomes levoversion and this becomes your levo elevation. Easy hai? This is the left side, this is right, this is left. So we have to answer for her dextro depression. I have explained you in the earlier session in detail about action of muscles. When I say divided into 2, depression, what are the muscles which depress? क्या पढ़ा है? Inferior rectus, superior oblique. Okay. Dextro, which eye is outward in dextro? Right eye. Outward eye में which is the sole action of elevation depression? Rect eye. So easy. So this is how you will know. It was dextro depression is the gaze they are asking. This was, they are asking, this is my question actually. So this is a dextro depression, ठीक है. अब इसमें depression क्या हो गया? Inferior rectus, superior oblique. These are the muscles which depress. Dextro is outward, towards the right eye is outward. So outward eye में inferior rectus काम करेगी and the other eye superior. So don't forget this. In outward deviated eye, sole action of elevation and depression is of rect eye, and the other eye is inward deviated. So when I say dextro depression means this one. Sorry, not elevation, depression. So in dextro depression, what is happening? Outward eye ka rect eye. So right inferior rectus and left superior oblique. Easy hai? Yeah, Avantika, perfect. So this is how you will answer. Chalo, let's come to this question. Okay, he is a 53-year-old male patient. Gradual diminution of vision where left is diminished more is type 2 diabetes and hypertension. So what is happening? Left eye में best corrected has gone up to 6/24. Slit lamp examination we see lenticular changes. Fundus picture जब देखते हैं we see multiple microaneurysms in both eyes in the macular area along with few hard exudates. So even fluorescein angiography is showing you multiple hyperfluorescent dots. What is the most probable diagnosis? You all will tell me. My question is, before I move further, what stage of D? Of course, he is a case of diabetic retinopathy with microaneurysm being the earliest sign, but he has hard exudates also. So what stage of diabetic retinopathy? Everyone should revise the ETDRS classification. I have taken that in earlier session. ETDRS classification पे question आता है. Okay, so can you think and let me know? And when I say lenticular changes, what lenticular changes you expect in a diabetic patient? Roy, please थोड़ा ध्यान से सुनो, सोचो. My question is which stage of non-proliferative DR? You are answering me PDR. No, this is an NPDR. PDR तब बोलेंगे if there were neovascularization, new vessels, isn't it? Pihu, which stage of NPDR बच्चे? Which stage of NPDR? ये बताओ. So this is what very quickly you should remember. So see, these are the exudates this patient has, and these are the microaneurysms we see. So it's a mild NPDR. Very quickly, let me revise with you. NPDR was I have explained you. I think this is a repetition. I'll go very fast here because I've done it. Recent is very mild, moderate, severe, very severe. So revise karoge. Okay, this is important. When I say very mild, these are only microaneurysms, then you call it very mild. But when there are hard exudates also and other features, hemorrhage exudates, now you call it mild NPDR. Okay? That means these are all the features of background diabetic retinopathy. And what is moderate? when there is looping of veins, large venous infarcts, है ना, these are pre-proliferative diabetic retinopathy के features. And what is severe NPDR? We have learned 4:2:1 rule, and if more than one criteria, it becomes very severe. More than one criteria of 4:2:1 rule, it becomes very severe. I have taken this in the earlier session also, listen to that as well. ठीक है? Okay. So we come to what are you looking at? We will see lenticular changes. This is exam question. In diabetes, what you get is snowflake or snowstorm cataract. So this is snowflake or snowstorm cataract. ठीक है? अच्छा, अब इसके बाद और देखते हैं क्या हम, multiple microaneurysms. This is how you see as hyperfluorescent dot on fluorescein angiography. This is again we are talking about. So here I can only say this. It could be even very mild or mild. Again the same microaneurysms. This is looping. Looping means pre-proliferative, or you can say moderate NPDR. When there is looping of the veins, this is moderate NPDR. And now, Roy, this is proliferative. Why? See, all the things you can recognize here. This is flame shaped hemorrhage. The red arrow is showing you flame shaped hemorrhage. White one is showing you cotton wool spots. Then some hard exudates on the green one. Then dot and blot hemorrhages on the blue one. And this is such a large cotton wool spot. And look at this one. What do you see on the disc? We see a tuft of new blood vessel here. So this is a case of proliferative, and this is NVD, neovascularization at the disc. Okay, got it? And now all of you sit straight, sit straight. I know you all are getting tired. I am also getting little tired, but we will finish it off. All of you. Now what is this? Is there any change in the fundus? क्या है ये? जल्दी जल्दी बताओ मुझे. These are laser burns. I have already labeled it. This is PRP. When it gets old, these laser burns look like this. You have a question here. PRP, can you see these straight burns? This is how we first make a boundary so that you don't enter the macular area. You are at macular area in PRP. From where you should start? Start from the inferior quadrant. Yes, very good. All of you have answered correctly. Start from inferior quadrant. क्यों? अगर आपने superior पे दिया any bleeding, the hemorrhage and the blood is going to settle down, then inferior will be not visible. Chalo, come to the next question. The best method, this is again your AIMS question, the best method to monitor siderosis. Siderosis is iron in the eye. We will do repeated ERG. Okay, siderosis mein what are the things happening? First is your lens pigmentation, then there will be iris pigmentation, and finally it will affect the retina. In the retina, when you do the ERG, what you get? You get a diminished B wave. Okay, yes, very good. All of you are answering correct this one. Oh wow, your name is Kishore Kumar. That's great. Huh? Do you sing also? Just joking. Anyway, so what is this? This is you're looking at iron deposition. This is a siderosis where you see these deposits on the lens. Okay, you are seeing it on the lens. And these are iris pigmentation. These are iris pigmentation. I thought you are getting tired, Piyush, so I thought thoda thoda हंस लेते हैं. चलो next पढ़े. Awesome, Kishore. That was a perfect answer. We'll listen to your song one day. Okay, we come to the next question here. Optic nerve meningiomas, identify the correct statement. So you all should be very, very clear about meningiomas. Quickly, let's revise. Meningiomas, if you want to write, you can write it. Okay? Is mainly in the middle-aged females, whereas optic nerve glioma, it is in the children, female children. First of all, you should remember this. Optic nerve glioma is from astrocytes, meningioma is from meningoepithelial cells. Okay? Okay. What is very important to remember regarding the pathology in meningioma? It is psammoma bodies, whereas in case of your optic nerve glioma, we will remember, this is exam question, most common pathological type is pilocytic astrocytoma, where the tumor cells are hair-like. I hope you are noting down. Let us come to this question. Optic nerve meningioma, identify the correct statements. It is a tumor from meningoepithelial cells. Yes. The most statements बोल दिया, that means we have to just identify the correct ones. The most common patients are middle age. अच्छा ये भी हो गया. Yes. It is mainly associated with psammoma bodies. ये भी हो गया. What is wrong then? Is this wrong? CT scan shows tram-track appearance of the nerve. Didn't we see tram-track appearance? Tram-track तो होता है. We have learnt it. So, it is an MRI finding. So, that is why this is wrong. Okay? Let's have a look. These are the psammoma, calcified lamellar bodies. These are the psammoma bodies. Another thing that you will know about meningioma is, don't forget, opticociliary shunt. They can ask you this. Opticociliary shunt. Okay? Then we talk about this one. So, here this is a coronal section, and what type of look that you get here is, this is also called bullseye, and this is a tram track appearance. Okay, on axial section, the tram track, don't go to the arrow, this is the arrow, this is what is tram track appearance, right? Whereas here, this is your coronal section in, this is all MRI finding. What you see here is your bullseye. This is also called bullseye sign. Okay? Yeah. Then we are looking at this one. Very important. This is CT scan finding of meningioma. Please make a cue. It shows you tubular enlargement of the nerve. It is the tubular enlargement of nerve. And can you see even the calcification is seen here. Yeah, cola bottle. And what about this one? This is your optic nerve glioma. Why do you say so? Very important exam question. So, this is what is the fusiform enlargement of optic nerve. This is the fusiform enlargement of the optic nerve. Rest of the points I have just told you about optic nerve glioma. What is this you are looking at? Can you see, it's a just intraconal space behind the eyeball. It looks very clean and encapsulated. This is cavernous hemangioma. We have learned what? Cavernous hemangioma is the most common benign tumor of the intraorbital tumor in adults. Most common intraorbital tumor in adults. Okay? Done? Okay. We come to the next one. Now, this is more irregular mass. This is actually varus. See, on post contrast vasalva ke baad, what do you see? These are orbital varices. Please remember, the only cause of intermittent, एक होता है pulsating proptosis, एक होता है intermittent. So, the only cause of intermittent proptosis is your orbital varices. Hope you will not forget this. ठीक है? ये क्या? Can you all tell me this one? This is for you. All of you quickly answer this. Answer karo, I am waiting for this one. What is the finding? Can you see the tendons are spared here and only the belly of the muscle is involved? Very good. Awesome. This is thyroid eye disease. You are looking at thyroid myopathy. How do you see that? That generally it is only the belly which is involved. Right? So, I think this one was cola. Anyway, now we come to the next. What do we have for this? The question here is, so it is again the thyroid myopathy, and now what is the question? All are true regarding the below clinical condition except. Okay, let us see. The sequence of the muscle involvement is this: inferior rectus, then lateral rectus, superior rectus, medial rectus. Force duction test is positive. This looks correct. It spares the tendons. Yes, it does. Or the sequence is this. Okay, so we have to land up into which sequence the involvement is. Should I teach you how to learn it? Make this diagram. So, you will see this diagram in my book also. I hope you all are aware of my book, Review of Ophthalmology, 7th edition. Anyway, so this is again a diagram here. like this, which will you will always remember the sequence very nicely: inferior rectus, medial rectus, superior rectus and lateral rectus. This is the sequence of involvement of recti muscles. So first involved is always inferior rectus. This is a question, and last involved, if they ask you, it is the obliques. Okay. Okay. Come to this one. So this is the last question of the day. All of you, look at this one. What do you see in the figure here, in the slide here? This child has a left eye hypertropia, right? So if the child has a left eye hypertropia, on opposite head tilt, when the head is tilted on the opposite side, what do you see? Hypertropia is not there, isn't it? But when same side head tilt, it increases. So what is the diagnosis? Same side tilt, hypertropia is increasing. I have taught you in the last session also, this is called Bill-Chosky sign, isn't it? This is Bill-Chosky sign, correct? So which side SO palsy is this? Same side head tilt, hypertropia increasing? Left SO palsy. Absolutely very, very simple to answer. It is left SO palsy. Very nice, Roy. So whenever in SO palsy, what we will remember, the 2 points I told you: same side head tilt and opposite gaze if hypertropia increases. Okay. So if hypertropia is increasing on same side head tilt and opposite gaze, then this is your SO palsy. Very good, Roy, you will do you will do wonders, don't worry. You have to just keep working hard. Okay, perfect. Okay, so that was the discussion today. Try to learn things in and around. If you find yourself weak in any topic, please listen to the earlier sessions 1, 2, 3 parts so that you have a very thorough revision before your exams. Okay, so one last thing for you all, let's learn this. Let's read it together. This is the thought for the day, so I always do that. So yesterday I got a message from one of the old students who mentioned that he really values all the thought for the days I used to give at the end of the class. So I realized that why I have stopped giving those thought for the days. So I have started giving it again from today. Okay. So let us read it together and understand. Our greatest glory is not in never falling, but in rising every day, every time we fall. Isn't it? We all fall. It is absolutely natural to fall, but please get up by yourself. No option of getting demoralized, no option of giving up. Never give up. It is like disrespecting yourself. Keep fighting till you win, and there is no reason you will not win. Okay, so all the best, all of you. Blessings to all of you. Stay blessed, keep smiling. Any questions? I will wait for 1 or 2 minutes before I end the session. पीहू, इफ़ यू डोंट, पीहू तुमने वो एक सुना है, कहावत हिंदी में भी है कि गिरते हैं शेर सवार ही मैदाने जंग में, तिफल क्या करेंगे जो घुटनों के बल चले. So people who will fall are those who will really run or walk, ना. So not at all falling will hurt more. ठीक है. So it is absolutely natural. So the more you are hurt, the more you become strong, isn't it? How is gold formed? क्यों पीहू? Yes. अच्छा अखिल, Park 3-step test. Okay Akhil, let's do this one also. Park 3-step test. In my own way I am explaining you. Just listen. I'm not writing anything, explaining you. So you have a patient. ठीक है? Park 3-step test is nothing but 3 questions to be answered. First question, which eye is hypertropic? So खुद सोचो, if these are the 2 eyes and this eye is right side I say is hypertropic. ठीक है? Akhil, are you there? Yeah. So if right eye is hypertropic, do you realize it could be the left eye which is lower or it could be the right eye which is upper? भाई normal ये है, but now I am getting like this. So either the depressors of my right eye are not working or elevators of my left eye are not working. यही है ना? ठीक है. So suppose now what you do, so which eye is hypertropic? It is right eye. ठीक है. That was the question number 1. What do we have the muscles in our mind? We have depressors of right, elevators of left. 4 muscles here, 2 here, 2 here. Now you will ask the patient that look to right or left. So your next question is, in which gaze the hypertropia is more? ठीक है? Now if the hypertropia is more in the left gaze, ठीक है? So first, okay, I will have to write something here to explain you. चलो यही लिखते हैं. So if I say right hypertropia, Akhil, if it is right hypertropia, right eye is up, left eye is down. What was the first question? Which eye is hypertropic means what are the questions, muscles in question? Right ka depressor. What are the right ka depressor? What are the depressors? Right inferior rectus, or what is the other depressor? Is right superior oblique. यही है ना? Or it could be left eye elevator. What are the left eye elevators? Left superior rectus or left inferior oblique. हो गया? अब आओ क्वेश्चन नंबर 2 क्या था? क्वेश्चन नंबर 2 कहता है in which gaze it increases. Suppose in this case I say it increases in the left gaze. So left gaze में if it is increasing the hypertropia, what are the muscles in the left gaze in question? Left eye is abducting outward. So if left eye is outward, recti will work, left superior rectus, and right eye is inward, oblique will work, right superior oblique. So if the hypertropia increases on the left gaze, what are the 2 muscles in question now? It is left superior rectus and right superior oblique. Now we will be answering the third question, in which head tilt the hypertropia increases. If I say it was right side head tilt, ठीक है? So if the hypertropia is increasing on the right side, higher eye oblique is involved. Just remember this. That means on tilting to the right, अब 2 ही जो question में है ना, what are the muscles in question now? Before you come to the third question, you have already zero in on these muscles, right superior oblique and left superior rectus. ठीक है? Now what you are saying, if on moving to the right, the hypertropia is increasing, it is obliques which are involved. So same side tilt में any hypertropia increasing, it is the obliques. But if it is on the opposite side of hypertropia, जिस side पे है उसके opposite side it is increasing, it is the recti which is involved. So in this case I said it was right tilt, say hypertropia was increasing, so my answer becomes right superior oblique. Let me tell you, they won't ask you in that detail, and you should also know the explanation of the thing, why it is happening, because when you tilt the head on the same side and if there is a right superior oblique palsy, I hope you know this, that both superiors are in tortoise. Now superior oblique is not working, सारी जिम्मेदारी किस पे आ गई? Superior rectus. Overaction of superior rectus leads to elevation. So that is the reason, right? Okay, Duane's retraction syndrome is an ocular motility defect. It is a congenital defect where the nucleus of the 6th nerve is not formed properly, and therefore it is the lateral rectus is innervated by the 3rd nerve, and therefore what happens is any attempted adduction leads to co-contraction of both lateral and medial rectus. This leads to retraction of the eye inside. This is Duane's retraction syndrome. समझ आ गया? फिर से बोलूँ, any attempt of adduction leads to retraction of the eyeball inside due to co-contraction of medial and lateral rectus. So when you look into it, there is a defective 6th nerve nucleus. It is not working properly. This is the Duane's retraction syndrome. ठीक है? Vision center with Walter. Are you fine? ठीक है? Okay. So now rest of the questions we will deal later, or you can say you can directly DM me and I am going to guide you. Don't worry, you can ask anything. Your teacher is never away from you. Okay, so thank you so much. Stay blessed, keep smiling. and keep working hard, never give up. Thank you.